and keep on asking questions. Okay.
Thank you so much, sir. And thank you for making the audience at ease for the session. Now, I would like to request Dr. Kavita Sachdeva, ma'am, to please come on the stage and address the audience.
आदरणीय डीन डॉक्टर सिद्दीकी सर, डॉक्टर पाठक सर, डॉक्टर वाधवा सर, समीर, सुमित, हम लोग के सब टीम मेंबर, अनिरुद्ध, सुशील एंड वी हैव फीमेल ब्रिगेडियर ऑल्सो। तो बहुत अच्छा लग रहा है, अपन सब मिल रहे हैं। एंड जैसे सोहित ने बोला कि हम लोगों को पिछले बार भी हम कनेक्ट हुए थे, तो दिस वेबिनार वाज प्लान्ड इन 2018, पर हम 6 साल बाद कर पा रहे हैं कोविड के बाद। और मैं बता रही हूँ, छोटा सा बच्चा 6 दिन का आता है विद रेस्पिरेटरी डिस्ट्रेस, समझ में नहीं आता है कि ट्रेकेस्टोमी करेंगे तो फिर क्लोज कब होगी वो, कभी ट्रेकेस्टोमी बंद होगी कि नहीं, सबग्लॉटिक स्टेनोसिस है या अंदर हिमेंजोमा तो नहीं है, सब कैपिलरी हिमेंजोमा, इतना स्ट्रेसफुल लगता था। तो मैं बैंगलोर भी गई थी, बैंगलोर में डॉक्टर रमन है जो इसे बहुत काम कर रहे हैं, बट डॉक्टर सोहित के जो फ्लो ऑफ थॉट देखे कि व्हेन ही पेशेंट इज कमिंग तो आप ऐसे करो, तो ऐसा लगा आई हैव गॉट अ राइट टीचर, he is a perfect teacher to let us develop this field. So thank you Sohit, and I'll not waste much of your time. Thank you for coming.
For all the online audience, I would like to announce that the session is now being started. So sit tight and enjoy.
Okay, so So the way we have planned the day is essentially, we will start off with some very basics of pediatric airway, and then we'll keep on advancing as we go through the day. At the end of the day, Dr. Sachdeva actually wanted to do some actual live surgeries, but I found it would be better if we just go into details of surgical videos and essentially go over the whole surgical procedure on a video. Oh, wonderful. Oh, they are half our friends here. Okay, excellent. Can we get started now? Okay. So the first talk which I'm going to talk about is a broad overview of pediatric airway disorders. And we're going to start off with some anatomy which is relevant to the peds airway. So when we look at a pediatric airway, it's very different from the adult airway. And there are reasons for this, why nature gave us a different airway as a child. So one of the most important things which we have to remember as ENTs is the epiglottis of the child is way high up, and it actually touches the soft palate. And the reason nature gave us this mechanism is so the child can suck, swallow, and breathe at the same time. And one of the things which we have to remember while we look at this picture is you can see the epiglottis is very high up and touching the soft palate. So kids are actually obligate nasal breathers. They can only breathe through the nose. That's very important to remember. A newborn is only able to breathe through the nose. We learn how to breathe through the mouth over a period of 3 to 6 months of life. So we can very well think the nose is blocked in a child because of the bronchial stenosis, or just by nasal congestion, it's not able to breathe properly. So that's one of the most important things we have to remember as we progress throughout the day. The second thing you have to remember is kids have a suck, swallow, and breathe pattern. They can suck, they can swallow, they can breathe at the same time. We cannot. We have to stop respiration for us to initiate a swallow. And that is why if a child is unable to breathe properly, he won't be able to feed properly, and he will be able to thrive. So that's the relation we are developing. So when we see about upper airway sounds, I'm not sure if the video is audio is play, but there are two important sounds which, as a resident, you need to understand. So I'll make those sounds. So one is is what we call a stutter. Stutter is essentially a snoring sound, which is caused by collapse of laryngeal airway, which is fine. You don't have to worry about stutter. That's snoring. Nothing bad is going to happen to the child. The second sound is a high-pitched strident sound. Keep the sound in the back of the mind. This means there is airway obstruction at some level. If that is a cause, you have to evaluate that further. Sometimes both of them occur together, and it's very hard to figure out whether the child is stuttered or whether the child is having strident. But try to focus more on this high frequency, high pitch sound. Ask the parents, does the child make the sound? That's very important. But it's more of a snoring sound. So that's the first question we always ask the child which comes to us with any airway problems. So the first thing is you made the diagnosis of strident. What next? The next thing you have to do is take a stethoscope and try to listen with your ears. Is which phase of respiration is it happening? Is it inspiration? Is it expiration? Or is it happening in both phases? That is very, very, very important, because if it's happening only during inspiration, it means extrathoracic obstruction. It's non-life threatening. It could be laryngomalacia simple. It could be any supraglottic mass, or it could be vocal cord paralysis. But if it is happening during the expiratory phase, then that basically means there is something going on in the intrathoracic airway, and that would be either tracheomalacia and bronchomalacia, and they are pretty life-threatening conditions. Last is if it is biphasic, meaning it's happening both during inspiration and expiration. That means there is a fixed obstruction in the airway, which means it could be subglottic stenosis or bilateral paralysis, which makes sense. Like if it is happening only during inspiration, that means it's dynamic. It is dependent on when the airway opens up and when the airway closes. So you don't have to worry about it. But if it is fixed, that means it's happening both during inspiration and expiration. That means there is a fixed lesion, and most commonly in subglottic stenosis. We're going to go back and then this video actually takes me. So the first thing if a child walks into your clinic with strident is you do a flexible scope. And flexible scope size is something that we get asked whenever I'm presenting. So we use a 2.9 millimeter flexible scope. 20 years ago, we used to think it will go into laryngospasm, and we spoke to the child and this is big. Nobody goes into laryngospasm when they go into laryngospasm when they are under anesthesia stage. So if you are awake and the child is fine and is not overdosed and is not sedated, he will not go into laryngospasm. So you can smoke as many babies as you want without resisting laryngospasm. The first step is to put a flexible scope to the nose. Start evaluating what is the cause of the airway. So, what is the cause of the airway obstruction? And when we start evaluating from the tip of the nose, we start looking at the opening of the is it wide enough across the scope? Is there a septal perforation? You go back, you get the vena open, you go down, you get the back piece of the tongue, over there. And then you look at the epiglottis, look at the vocal cord. You do a complete evaluation. Don't miss the nasal part, because you can have you can have cyst in the nose, or you so your complete evaluation of being flexible fiber optic first step you should do it without don't worry, something bad is nothing is going to happen. Okay, so now that you've evaluated the child, what's next? So you found some evidence. Maybe the piriform approach scenario, maybe the child had corneal stenosis, maybe the child had laryngology. So what is the next step? Next step, what I do, and many people don't do it, or sometimes they do it, but it's very relevant to your setting over here, is to do a chest neck X-ray, which we call as a high KB probe or an adenoid series, because the exposure is a little bit more, so you get better soft delineation on the next one. For example, we all know about the thumb sign and epiglottitis. This is how you can see. You can have the steeple sign, which is on 2. You can have subglottic hemangioma. So this is a subglottic hemangioma in a child. So you get an AD and lateral view. What this does is basically give you a more of a screening tool. When you take a child for a bronchoscopy, or if it's nothing wrong in the distal airway, it's probably just laryngomalacia or probably nothing major is going on. So this is a very nice X-ray, which I would recommend doing in your setup or any child with stridor. And make sure you do an AD and a lateral view, and it's a little bit more high KB or high kilopole, in which the exposure is a little bit better, so you can see the small lesions. The next question becomes is, should I do a flexible bronchoscopy with my pulmonary disease, or should I do a rigid bronchoscopy? So as ENTs, we do rigid bronchoscopy. Now we do flexible as well, but rigid gives you a much better resolution. The rigid gives you an opportunity where you walk in the airway if something bad comes up. So the next step is the rigid bronchoscopy. And I have surgical videos for the end of the day. We will all be tired and sleepy, so they keep it interesting. But just briefly, this is a child spontaneously breathing. There is no endophrenic entity. So all pediatric airway surgery is essentially done on a spontaneous respiration. And again, you put a normal laryngoscope, whether it's a lymphoma or a ventral, you expose the airway. We just use the Hopkins non-telescope. We don't use the full bronchoscope because the child is breathing by himself. So I really don't need to put a ventilating bronchoscope. I'm just using a whole bronchoscope, and I just push it in. We topicalize the airway. And again, we'll have a discussion about how to do a diagnostic bronchoscopy. But we evaluate the airway. That's the next step. So now we are going to any questions about the evaluation part? Anything which pops up on the slide? So there are indications of doing bronchoscopy in a child. There are indications of doing bronchoscopy. Not every child with stridor. If I can't find a diagnosis on my flexible, then of course I will take it for a rigid bronchoscopy. If I plan to do something with the child, then I will take it for a rigid bronchoscopy. So the initial diagnosis is just flexible diagnosis. The flexible diagnosis, no, we don't know. Some people put lidocaine in the nose, but the babies never try it. Lidocaine in the babies. Okay, so we're going to talk now about common causes of stridor. What do we usually see? And they can be briefly divided into, of course, as the airway goes, larynx, trachea, distal airways. And we'll talk about a little bit of common causes, then we'll get more rarer things. So from a laryngeal point of view, the most common cause, as we all know, is laryngomalacia. But one of the things which I really want you to know is not all stridor is laryngomalacia. That is what we are usually taught. If a child comes with stridor, it's laryngomalacia, not all causes of stridor or laryngomalacia. Only 60% are, and 40% will be a number of things which can actually cause a lot of things if they are missed. Okay, so let's start with Okay. As long as you can hear me, I'm fine. Okay. So let's start with something very common, which is laryngomalacia. So what is laryngomalacia? It's the most common congenital anomaly of the larynx. So the typical thing, the first question you ask a child which comes to you with stridor is, when did this start for the child? If the parent says it starts right at birth, then it points towards something different. If it starts a week or 2 weeks after birth, then it's probably laryngomalacia. That's when laryngomalacia starts. And the question which comes to our mind is, it's a congenital anomaly, why is it presenting right at birth? Why does it present? And the reason it does is, as the child grows, his airway requirements grows, and that's why he's spending more air. And if you remember your basic physics, the more turbulent air goes into the airway, the more noisy the breathing is. So that's why it takes a week or 2 weeks to present. And then it gradually increases over several months and starts to resolve. And by 2 years, most of the children have complete resolution of laryngomalacia. It's an inspiratory stridor. Child suffers that inspiratory stridor laryngomalacia. Feeding difficulties, as we all know now, airway can produce dysphagia, so they are feeding difficulties. And the child will present coughing, choking, regurgitation, and slow intake just because of all these feeding difficulties. The most important thing to remember is most of laryngomalacia is associated with gastroesophageal reflux. So it's a vicious cycle. The child has reflux, he is refluxing, he's irritating his voice box, swells up more, he gets more laryngomalacia, he's exerting more, gets more reflux, it becomes a cycle. So we have to break that cycle. The classical triad of laryngomalacia is that on omega-shaped epiglottis, tight eri-epiglottic folds, and bumpy epiglottis. And we classify laryngomalacia into 3 types. One is type 1, which is basically there is redundant tissue over the rhinoid. You can see how it's not. One is very tight AE folds. So you can see how the AE folds are tight. The eri-epiglottic folds as a child is an empty breathe. And lastly, there is a complete epiglottic prolapse, where the epiglottis just gets. So those are the 3 common causes of laryngomalacia. Again, you'll be able to diagnose this on complex cases. So it's pretty simple. The next thing we usually do is what we call as a piece or a functional endoscopic evaluation of swallow. You must have heard adults and it's pretty simple to work with a speech language pathologist. When you spoke the child, you actually have the child eat at the same time. And you can see if the child is aspirating or whatever the swallowing dysfunction is. It's a very, very important information when you have this immediate. So this is how a piece looks like. So this is a larynx scoping, and then we have the child eat something which is colored with a green dye. You can use anything like you can even use Coca-Cola or any green dye. You can color any food, and you can actually see how the swallow is happening. We are looking for that green stuff going into the food pipe rather than the child aspirating. And you're looking at the laryngeal penetration or the frank aspiration, and you'll be able to see it. The more you do it, the more cheap your eyes are going to be. So this is a piece in a child with laryngomalacia. You see very tight AE folds, and then once you do a piece, you'll be able to see there will be some premature spillage. The child has some penetration. It goes in the back, and then it goes into the ear. You'll be able to pick it up, and you can see if the child is aspirating or not. Okay. So now we have the diagnosis. We evaluated the child. We know it's laryngomalacia. What to do about it? So if it's mild laryngomalacia, the child just has a noise, not having severe airway symptoms. You just do some medical management, which involves managing your reflux, because we know reflux is associated with laryngomalacia. We have to manage the reflux medically. And how do you manage the reflux? You thicken the diet. You have the child rise in the form of something. And thickening diet will stay down. It's not going to come up. It's difficult for the child to reflux. That's one of the things you manage reflux. Thicken the feeds, pace the feeds. Don't give the child all the feed in one. With 4 ounces one, take a break, with 4 ounces more. So you pace it. And then you do medical management. You can start them on ranitidine or omeprazole, whatever is available. We usually do it for 3 to 6 months for reflux management before we take the child, which surgery that has been made. And these are mild cases. But when you operate on this child, and we have started with more and more of these surgeries. One is the child has started developing the pectus because he's exerting so much, he's actually developing the pectus. The second is the child is failing, right? That's the most common indication of rhinoplasty is failure to right. The child is having weight loss, the child is having sleep apnea. In all these conditions, you're attempting the child back to operating rhinoplasty. So this is a child, he's having some, there's no sound, usually you'll hear a stridor, and you can see what is going on in the airway, it's an inspiratory sound. You can just hear it even without the sound. And when we take him to the OR, you can laser the supraglottic tissue. Again, you will have a surgical video afterwards, and again, so going into details about how this is supraglottic. And you immediately see an improvement, like from that airway to this airway. It's a pretty simple procedure, it takes us 3 minutes to do it. So that was type 1. This is another child, severe pectus, like he's developed severe pectus deformity. And this is what is going on in the airway. It's practically no airway. It's very tight, can barely breathe. And again, I use a laser for this. We can use cold steel instruments. You laser the A poles and it opens up very nicely with the must and see which difference is a child. The pectus is used as an easy better. So, any questions about laryngology? Good. So the most important thing you remember is not all stridor is laryngology. So this is the kid referring to my clinic, biopediatrician. Hey, this is stridor, it's been resolved, but the child is not giving weight at all. So we scoped him and he had this massive so the reason I show this is just to get that into your mind is not all stridor is this is easily manageable. We use a microdebrider, now we use a laser. Same with this case. The kid had a history of intubation. Whenever there is a history of intubation with stridor, always with a prognosis. It's very simple. Like intubation stridor is equal to prognosis. There is no question about it. Because the child might have subglottic cyst, or the child might have subglottic stenosis. So always do a prog in these kids. Yes, this is how subglottic cysts look like. They are bilateral subglottic cysts like a 2-month-old child history of intubation. This is a child with laryngology cyst. Again, a big laryngology cyst right in the laryngula causes severe airway obstruction. They can try easily removable with the laser or steel instruments, and you make a huge difference in that child's life. So now we're going to digress from stridor to something more, which is increasingly getting more common, is what we call as a laryngology habit. We'll hear more and more discussion on laryngology habits. As we all know, the larynx, the airway, sometimes they don't use together. That is essentially the so you can get it so what will be the next step? China wants to do the next step then you take the time for that. When we look at that, and then we want to type 1 assessment, the analysis is one in the preparatory projects, and and then some way type 2, the microproject type 3, Who in the system of the type 4 was all around the like these are our same things we use it more than it's a bit of so one of the things I don't know how many things which were in the pretty one is pretty common, one is the house. Then we start to get them out very quickly. So the way they diagnose them is not the way they diagnose them that so how do we diagnose it? So this is children and hormone needs, spikes and energy for and what would we be doing with the this is a theory of you try to blood out spend in the child, you have an energy goal and you find and how do you repair it? Basically, inside the margins, freshen them up, the stitching. So it's a very difficult stitch to put initially, but then eventually once you get used to it, it becomes easy. So in this, I'm using like straight scissors and we have a fashioning margins. And then we have to use actually needle. It's a very, it's not a so in this case, it is fine or white. The thing to remember is you're not pretty common sense on the airway. So it has to go from the patient's level to the back. We'll discuss this surgery the last session. So these are various type 1 laryngology tests. Any questions about
Just same question, how will we evaluate under the GA or just you can palpate it under without any preparation?
You have to take the child for a rigid trauma.
Right,
Take him to the ward, and the child like this suspended laryngology.
right.
Then you use a suction or any other instruments to go that area. You will be able to see a density of the interval. Sometimes it will way down. When that happens, that's a true so the gold standard for diagnosis, that's a question we ask. What is the gold standard for diagnosing the management of rigid trauma? Okay. So the next thing which Dr. Kavita actually mentioned in the morning is subclonic hemangioma. And again, you can make a diagnosis or at least make a differential based just on your history. So subclonic hemangioma is anywhere in the body 4%. So that's the number one point. Hemangioma is always present at 2 months. Very, very important. It's in the neck, it's in the airways, anywhere in the body, it always presents at 2 months of age. So it usually presents at 5 weeks of age. So if a child comes to you with stridor, is 1 year old, 8 months or 7 months old, and you ask the mom, how long has this annoying breathing been going on? She says she was fine when he was born, but then in 2 months' time, we focused on stridor, and since then it has gone on. That is pointing towards the subclonic the trick about subclonic hemangioma is 50% of the kids die because we fail to make a diagnosis. So you can very well imagine it is such a misdiagnosed issue. The kids die at home and we don't even know what the cause was. The thing to remember starts at 2 months, proliferates up to 1 year, and that is with all hemangiomas, and then they start to evolve from 1 to 5 years of age. But in airway, you don't have the luxury of waiting. You can't wait until it starts, and you never act quickly. If the hemangioma is on the neck, on the face, or anywhere in the body, you can break it. And it's a fixed lesion, so it is going to produce 5 days extra. By now, its classification is something goes in the posterior lateral, and sometimes it's associated with cutaneous disease. If you ever see a child who has a hemangioma on the face, there is a 50% chance he has a hemangioma in the airway. You have to work with problems. So very important to stay the right and then there, because if you see a child who has like facial discoloration, facial always get a rigid process in the child. So it's almost a 50% mortality. It's a high mortality. How do we work up? If you get an X-ray done as a show, you will be able to see your and of course, your bronchoscopy. So how do we treat these things? So previously, we had very limited options. Many of these, it's together. Now we have a plan. Kanotra is in front of us for all it is a safe drug. The cardiologist uses it all day long. It's pretty common for them to use it. I usually use it as in a daily. If you're not comfortable with consult the cardiologist, you will start off and within a week you will see a huge difference. Like it acts pretty well. Within 48 hours, and while you are eating, some people inject steroid. Downside is if you inject steroid, you already reduced standard. So I usually avoid this. I do try this. If you plan to inject, keep the child intubated for a couple of days, and extubate in 2 days. That will change the purpose. So, yeah. So for granule injection is we have a laryngeal. So I don't know have over here, but it's a laryngeal and we essentially have a body and us speaking a lot. I injected 40 milligrams of analogs, 40 milligrams. Usually inject 0.26. It's a very little amount. And I try to inject on one side. And if we inject, I just need to try to inject it. Just this is when we usually takes 40 hours for so just a regular
Yeah.
That's a good question. We still don't know essentially how granule works. It was a very serendipitous company in France. They had a whole study in which they were doing using developments for heart failure kits. And they found heart failure kits which had hemangiomas. Their hemangiomas was already deeply on the problems. And they were like, okay, maybe we should start using that for hemangiomas. And now it's like so the way people have proposed mechanism is through VEGF inhibition. So it acts as VEGF inhibition and then the mass. And essentially we really don't know that. But that's the proposed mechanism of one study is VEGF inhibition. But any hemangioma anywhere in the body, say, started to do it. It's one of the miracle drugs in the pediatric. No, sorry. Yeah, I should have mentioned it again. So we are giving you panel. So it comes as a full drop. We give 2 milligrams per kilogram. We divide doses. There are a couple of things you have to look out for when you're giving the panel. One is I usually get it in digit channel without being hot dogs because you know it costs hot dogs. Second is a blood sugar very important with the blood sugar things. So those are the tricks. And if you don't want to go through all that, you just get a hot dog. Good. And then One of the other common causes is RRP. Again, it's pretty challenging. In the US, there's been, we all know RRP. In US, there's been a massive decline in the rates of RRP just significant vaccination. So when I started practicing, I used to do at least 4 or 5 meetings on RRP. Now I rarely see So we all know RRP is the most common benign neoplastic caused by HPV. Juvenile RRP is more aggressive than the frankly, and we see one where in juvenile it's not much of the So in adult, it becomes a voice issue. In pediatrics, it becomes a hair issue, just because it's presents with the triad systems. Child with the hoarseness, with the last one, child with the hoarseness and the voice of the cries and hoarseness. As including all items, it's tried depending upon how they get species are also the investment. This is a staging system. This is more than just have some documentation. Goes over where the ones are, and so you can keep as you progress down the line, keep in mind. So what do we do about it? You make a diagnosis. This can be technical scopes. You won't have a child, an older child comes with a spider, most boys, flexible, see bunches of things. The next step is to take it a bit more and manage. There are so many different ways to do it. No, none is better than the other. I can do what I do. Mostly quantify the instruments available. One is simply second is which is actually a great way of doing it, which and the last is I use a combination of certain the most important thing that you have to remember is it's an infectious process. It's not an infectious process. It's a viral process. So you have to use some antiviral agent. I like any infection. So the most common agent we use is Sohit. And we do intravenous injection of Sohit. Previously, we used to wait for 1 or 2 sessions and inject Sohit. I recommend starting it together. Take the child bag, microdebrid, and inject Sohit right on 1%. It's pretty safe. The system gets optimistic long. And it's one of the things which you get experiences. There are other stuff, but again, those are more stuff. This is the most important thing. So this is a typical case. We can spend some time over here about the setup and everything because we have a nice photograph over here. So this is a trial. We start the video so we actually see our setup and understand how we are doing this. So this is a child. We suspend the child. This is a parson laryngoscope. You can use any laryngoscope. If you see the suspension is on a clear stand, you can use any. You're not holding it up the child. It's actually on a clear stand. And this is how we suspend a child. I have used sometimes when suspending, you won't get the exposure. So what we use is an external microwave pressure and the using our residence once you have a good view, we put a local spreader. It's important to put a local spreader in these cases. And you see it's put upside down. Because if you put it in as the way it's supposed to go, you won't have space. So we actually put it upside down, use a rubber band to suspend it. You can do it in adults, you can do it for anything if you have not suspension, you can use this instrument. And then if you see this is my telescope, that's about this is the micro reader. And all this is And once this is done, and again, we have one lens. It's half an give us a display where I can operate, child is not integrated, and I can do all this stuff on the child. But you can integrate it. This is possible. You can integrate the child literally might not right. So this regular micro treatment of the patient and I inject sit off in the same setting. And it takes a while. These are impressive lesions. Like they come back. And I usually take them every month. It will be just staged where it looks great. So make a schedule for these. The learning points in RRP. One is injections of day one. And number two, develop a schedule for them. Take them back 3 months. We just we have to get a one day might wow, this is all on. So I'll take care of. Good. One thing which I wanted to add about RRP is some RRP patients don't even respond to this. Now we are started to use bevacizumab, which is essentially the improvement of that is it's known as a fast. I don't know if it's available, but that's great for very, very aggressive RRP cases. Fast. I think this is. More about the problem we'll talk a little bit about now we're going to go a little bit more yeah. Like 3 that the only way to do it along very second thing is we are open and open are very close. But type 1 and type 2 and some type 2 but again you need good very you have to go in and instrument stitches is difficult, it's not an easy surgery. So it's 75 milligram per 5 ml. That's the concentration of salt. And I usually go up to 10 to 15 ml of salt. Sorry, 5 to 10 ml of salt. Like as much as you can. It's a pretty high dose. Avastin is systemic, so some people inject intravenously as well. I usually do it systemically. That's not a biochemical. So I really do it. It's a chemotherapeutic agent. They are very first starting.
Thank you, Susan.
So now we're going to talk about something which we don't like to do, subclonic stenosis. So what exactly is subclonic stenosis? Subclonic stenosis is any narrowing in the subclonics. Subclonic stenosis, narrowing in the trachea is tracheal stenosis. And subclonic stenosis can be congenital or acquired. The most common thing you guys see, we see in practice is acquired subclonic stenosis secondary to intubation. But some kids can be born with congenital subclonic stenosis. That becomes and it's a mixed obstructions. Now we all know it's reduce what it's striking because it's fixed obstruction. There will be restraining intubation. In older children, there's going to be exercise involvements. The parent comes in, the child runs around and gets shot. And pulmonology has developed asthma and everything else has a fast intubation. Then you'll essentially next step is to do an X-ray, make sure there is no sticky sign and there is one of the common presentations is recurrent improvement in child. Since the airway is already narrow, so even a little bit of inflammation could reduce. So if the mother comes and says, hey, my child gets almost 2 months, we give some steroids, but again, after 2 months, we get in those cases, you think about either a subclonic hemangioma, it's a 2-month-old child, or you think about something. So recurrent through again, indications for the process, and we can do a lot of things. We discussed about etiology of subclonic stenosis. We saw a lot of subclonic stenosis, especially now. Most of them were intubated. Post-extubation, they had a lot of subclonic stenosis. In children, luckily, as kids were protected by COVID, we had a very low incidence of subclonic stenosis in children after COVID and even tracheostomy in children. So, subclonic stenosis congenital acquired, we discussed it. This is a cotton wire breaking system that we use. You must have heard of grade 1, grade 2. It's a pretty simple system to use it. We all carry these cards in the section. Is you take an agent appropriate tube of the child, and if he's not accommodating that, you start off with the lowest tube. For example, if the child is 2 years old, let's take an example of a 2-year-old child. His age appropriate tube is a 5 tube. And as we all know, the size of the tube is the size of the inner diameter, not the outer diameter. So you can see a 2-year-old accommodating a 5 has 0% obstruction because that's an age appropriate tube. But if he accommodates, for example, only a 3.5, like when they put a 3.5 tube, then when you start seeing leak around the bubbles, he actually has grade 2 subclonic stenosis. So it's a 50% obstruction that comes in grade 2. Okay? And if he is able to accommodate only a 2.5 tube, and you see leak around a 2.5 tube, and you go back to the chart and you see 2.5 with 74% obstructions, it becomes grade 3. And if the child essentially has no airway, it becomes grade 4. So that's how we grade stenosis. This is another photograph showing all the types of grades. Grade 1 is 0 to 50, grade 2 is 50 to 70, 70 to 99. And this is the same grading system used for whether it's adult or pediatric. This is pretty standardized, and you should always grade and make sure you don't have to grade statistics. So what do we do about stenosis? So there are various ways. First, you have to grade it, grade 1, grade 2. Evaluation becomes a huge component if you start operating on these children. We'll go over the evaluation of grade. So for grade 1 and grade 2, what are our options? Grade 1 means the child has a thin, flimsy rare section, or an adult. Those are pretty easily managed. You can do endoscopy, you can use a whole knife, you can do knife the lesion, put a treatment and diagnose. The question becomes, what about with we'll discuss it later on. Just I know the answer to the questions. Or you can use laser and then but it doesn't work in higher grades. You have a thick scar, which is more than a centimeter, and if it's involving major areas of the hair, maybe it's completely clotting as well as subclotting stenosis, you have to do the and open airway. So how are you going to take care of that scar? Either you can make it bigger, or you can cut that area. There are only 2 ways to do it. You can make that area bigger. How will you make that area bigger? I use graft. What sort of graft I can use? Maybe replace it with something similar to training. What would that be? That's a so you can make it wide enough, make it possible. But if it's a grade 4, you can't make it like high. You have to cut out, and that becomes a secondary area. So expansion procedures, as I said, anterior graft, you're putting the graft only in the front wall. Posterior graft, you put a graft both in the front and the back wall. And resective procedures, which are microtracheal resections, like the combined procedures are way advanced. So this is typical grade 1, and we'll see videos of these at the end of the session. It's typical grade 1 grade stenosis. You can do a 4-quadrant incision, you can use a prosthetic sine, which is triangle, and put any diagram. You can do dilatation, you can use other diagrams. So I use a laser because I have access to a laser, and I love this laser in the air. This is a flexible laser, and it's pretty long. You can do this sort of process as well. And I'm lasering the lesion, and then I'll end up putting the balloon in the lesion. So this is grade 1 hidden flimsy scar, and you'll see it pretty often. Even after post-COVID, and in children will see kids get intubated and get extubated and have most extubations, right? And they move from see a thin scar, basically go in, you dilate them, inject steroids. It's very important to inject steroids altogether. Then you bring them back in a week. The same thing after a week, and after a couple of sessions. Very rarely it stays for longer than sessions. Then you start thinking about so we talked about subclotting stenosis. We talked about expansion procedure. Now I'm thinking about how to expand. It's very stenosis. It's not that bad. It's still in the airway, but we need an expansion procedure. So there are 2 types of cartilages which are available. One is the thyroid cartilage itself, and the other is a prostate. So for a smaller yielding 6-month-old child, I use a thyroid healer, and for a bigger child, I use a prostate. We'll go over the surgical we did with but this is an example of a child post extubation, a lot of granulation tissue, practically has no airway, daily, multiple attempts of extubation, taking to the OR for bronchoscopy, almost no airway to be, he's made a fail extubation, like NICU is not be able to extubate this child. So what will be the intuitive step? We have to tracheostomy is a huge burden to the family of the child. So what we did in this child was essentially do a thyroid relock. So the way you do this surgery, I don't have a video of this. So you expose the airway, and you take the superior flange of the thyroid, like that part of the thyroid which is in the muscle attached to the thyroid part. And this is graft is essentially 2 millimeters. So you don't need a big grab. 2 minute grab. Such a simple surgery can take it 15 minutes to do the procedure. Exposure of the airway, a small thyroid is taken. You make your trichotracheal split, you do a split in the cricoid, and then essentially put the rubber stitches and expand that airway by 2 millimeters. Intubate the child 3 or 4 days, 4 days. It's a very, very simple procedure because your graft is right there. The quality is being separated for you. And this is the child who was operated. We extubated and you'll see the graft. This is healed pretty nicely. And even you'll be able to see this area of the graft. Airways right over there. So not only it expands the airway, it actually releases some pressure in the airway and causes them to understand. So that's also another theory which we go over. So thyroid subchronic stenosis is less than 6 months, presenting as a failure stage. You need to pause in real exercise and chance. Spoke the child and you might take your child out of hospital. What happens if it's an older child? We are you can't use this it's very small. Then we use the process section. So this is a child who had been tracheostomized for comes to my office saying, hey, I need to get the trach. When you look at the area, there is significant suprastomal tracheostomy. So you won't be able to decanalize this child. He has significant suprastomal. So what do we do about this? So we actually do anterior. In this child, just suprastomal collapse, we did an anterior anterior. It was grade 3 that I would have done an anterior posterior, but for grade 2, we just did it. It was suprastomal collapse and anterior collapse sizes. This video is long. Unfortunately, I cannot move the video forward. So what I'm going to do is we're going to come back to the video later on. Any questions about NTR? We have a full like 30-minute video of NTR. You need the pericardium on the back. So you get it. Always, yeah. Pericardium is always in the middle, whether you use a pericardium so they can be that's a cause of failure airway but the small graft anywhere in the body, like even in here, using so the smaller graft like it takes take up because they need less plastic. They need less plastic because small. Thyroid usually takes up very nicely. Fast cartilage can happen and then the next, now we jump on into resective areas, and we all are familiar with trichotracheal resection. So that's one of the resective areas surgeries we do.
Excuse me, sir. Excuse me, sir. I have a question. Excuse me, sir.
Yeah.
What is your experience with tracheal stents? Using tracheal stents for stenosis, for recurrent cases, recurrent stenosis and all.
So tracheal stents, the way I was taught, never been used.
Okay, people use metallic stents and all.
Yeah, you're talking about absorbable stents, or you're talking about
Metallic
mesh,
stents. Mesh, yeah.
not the regular stents.
No, not that.
Stent or not those. So those used to be put a lot in the 1990s and 2000s. But the issue with those metallic stents is actually low. And we had bad complications. That's number 2 is they don't allow people to clearance to happen around the stem. So they usually get a lot of uses. That was a massive issue with those. And then you end up with the media construction. Number 3 is hard to remove and then they get it. So personally, I've used them once or twice. I use them for treatment in Asia, and I never So, but the other stents, the older stent which we use for laryngotracheal stenosis, once we are doing the posterior those stents are really used like a rubber stent, maybe they make the veins stuff like that. But the expandable and direct stent, at least to my knowledge.
Thank you.
So for trichotracheal resection, what are the indications again for severe stenosis, grade 3, grade 4, when you have no airway, up to the second airway? When there is a central spot, one of the questions which you have to know is what is the contraindication of taking a trichotracheal resection? And you need to have some area below the vocal folds where there is just down. So you need to have some disease-free area below the vocal folds. So this is one of the children who came post-extubation. We did a bronchoscopy, has practically no airway, complete glottocephalic stenosis. You can see a band or the complete process stenosis. And we usually replace with grammy, and then again, like I said, this is now has a disease like area, and now actually keeping it in an aggregate so it's a good summary. You have to have a right that you have to have a right category. You need to have a system of the middle of the disease area with the system. Next is regular development again. The thing to know, so those conditions and control this is the time to stay what is this? The way that analysis of doesn't go away. So this is a very important thing. This is the everybody, I work in one of the important things is that I don't think it's programs is that I don't think then we do also something to do like that. I have developed two evidence. Any questions about?
So it was very informative and it is addressing our needs. Thank you so much. It was informative. Like in later part, I would really like to know what about the thyroid cartilage repair, what type of suture you use and what is the protocol? And many people just like stenting, what is the role of stenting, he asked. Because that is the old trend that we put stent and then secretions, granulations make it all bad. The second thing is, you told about subglottic stenosis, sir. First instant at every health center is to do a tracheostomy and then it becomes a disaster. So what is your opinion that what should be done with this subglottic stenosis? Grade 1, grade 2 can sustain, but grade 3, 4, when should they be referred to a higher center and when should they be operated?
That's the easy way to do it. So there are things which you can do. I always teach my residents taking the videos right now. Because there are a lot of things which you can do for such a one of the most simple things, not everything. You have to graduate. Let's see who is happening. Most of the times it doesn't happen because it's a lot of granulation. So take it back to the operator. Any kid who is a failure extubation and you plan to train always doing problems. As long as the kid is unfunctional, it's okay. It doesn't need many, which I guess we don't have a lot of because the actually second kids on the whole and so even if the drugs are not better, train the child and they take it home and essentially spend the child. So you evaluate the area, it's not a granulation tissue, just derive the granulation tissue. Assuming which put a smaller tube there, and at the end of the tube, you use your Stobra axis. Stobra you can make a lot of Stobra X on the infiltrated tissue and integrate the triangle. If the most steroids possibly rejects steroid in that area, and then bring it back after 3 or 4 minutes. Again, you will see a huge difference in the area. But if the child is still failing, then you start talking about it. There are indications of it. Number one, the nutrition should be good. It's not a thing that is avoided. Number two, the child should not have severe issues. The heart function is not making the child have a system. So, but if the child is healthy, and this is the only issue for which he needs a tracheostomy. You essentially do a parallel. Again, it's pretty simple. You do like a parallel, it's supposed to happen like a parallel. Then you essentially take just this superior it's just this is and take it all on the deep layer to the right points. So do a frequency essentially. Just take a frequency then one of this is holds the ground, this is the ground, and then the microbiome and that's what we use to see on our don't have to see it's fine. That's something takes 15-20 minutes. But if you're able to avoid it, this is one of the surgeries that my nose to start with that. So if you think on that raw start avoid it, Just because you know that the person doesn't drink. So that's a huge thing and we want to develop it's practice. Start with this using the like make a difference in the child. This is a surgery which was in my hands at the time of the so it's a good decision. Single thing, yeah.
Right.
There's always a child who still fails extrication. I've had a couple of children who fail extrication and then you know try that and then they try. So training should be the last. Try to figure out ways we can avoid. Don't train each other. So this is not as a single stage because we are doing the instruction at once. The double stage reconstruction is when you train the child and you do a reconstruction with the train and you do a child is trained, you do the reconstruction about and take the train out of the latest stage. That becomes a double stage because stage single is remove the train, single stage and out of this is a double stage. And there are various ways you make that decision. Like if the child doesn't have a train, it will always be a single stage. But if the child has a train, you can do double staging till you develop that confidence of okay, I'm going to be successful in this my next talk is actually on tracheostomies. Do you want to learn about tracheostomies?
Sir, would love to know everything about tracheostomy also. You can have 5 minutes break.
Yeah.
You can come and sit, have tea with us. And in the meantime, those who have not taken breakfast, they can have quick breakfast break.
To all the online audience, we are taking a 5 minutes break and we will be starting soon.
Sound check. Sound check.
I presume कि आप लोग सपोर्ट करेंगे मुझे. Thank you all of you. We have 10 outside delegates who wanted to listen to your talk, so we have arranged a hybrid mode, but they are getting eco. That's why we are shifting this.
Okay. I'm amazed you've been able to organize this at such a short notice, like, it was like 10 days or something. You don't want to share? Okay, so I wanted to do this talk just because I know pediatric tracheostomy can be a little bit challenging and it's very different from adult tracheostomy. And I wanted to share my tips and tricks for making this surgery simpler, safer for the child as well as for the institution. So once we look at the indications for pediatric tracheostomy, and they have changed over the years. Like previously, we were doing a lot of these for infective causes, epiglottitis. But now with the H influenza vaccine, the indications have changed. Now, more commonly, we do it for need for prolonged ventilatory support, because we are saving these premature NICU babies who end up getting intubated and developing cephalic stenosis or need ventilatory support. So when do we trach a child? Like, even though my morning talk was think before you trach, this is more about when we actually have to trach a child. So number one is, if there is severe laryngotracheal stenosis, you did everything you could do and the child needs a tracheostomy now. Kids who have bilateral vocal fold paralysis, and we'll talk a little bit of bilateral vocal fold paralysis in the neonatology talk. Kids who have severe craniofacial issues and you're waiting for them to develop or wait for a mandibular distraction. And those are the kids you end up doing a tracheostomy. Or there are other subset of kids who need ventilatory supports. And as I said, we send these kids home with ventilators. So you need trach for the ventilator to hook up, and that's when we do a trach. Whenever you think about a surgery, any surgery you plan to do, whether it's a simple tympanoplasty, the first thing you think about is the complications. And then your whole surgery revolves around avoiding those complications. That's how I train my residents. Go read the complications first, and then you read the surgical procedure, because you need to avoid the complications. So the whole surgical procedure, whole tracheostomy, is basically done to avoid these three things which are commonly seen. One is accidental decannulation. The trach comes out and the child has no way to breathe and he dies. The trach comes out, you try to put it back in, but it goes into the false passage and the child dies. Or the child has severe wound breakdown around the trach or in the neck. So as I go through the surgical procedure, you're going to see how we plan the surgery to essentially avoid these three common complications which can arise from tracheostomy. So The photograph to the left is essentially how we position the child, and it's important. This is actually an infant. How we position the infant, and if you'll see, I've actually taped the so we put a very thick shoulder roll. Most of these children have chubby necks. Some of them don't even have a neck. You actually have to make a neck. So you have to have very good extension. So we basically use a very thick shoulder roll. You tape the shoulders down because when you do that, you get better neck exposure. And you tape the chin up to the table so you get full extension of the neck. So it's important to position the patient correctly. Yeah, so it's the same position I use for thyroid ALA grafts, same thing. Even if you have to do like a infant, anything you want to do in the neck, you'll end up doing something like that. But for trach, it's very important to have good exposure. So, and then we'll go over the surgical technique and we mark our incision. So I use a vertical incision. And once residents start reading about it, they learn about horizontal incision, vertical incision. It doesn't make a difference. I use vertical incision because you end up cutting the anterior jaw if you do a horizontal incision. So vertical incision is great for tracheostomy. And you mark it, you feel the suprasternal notch, you feel the cricoid, and just below the cricoid, you make a 1 centimeter vertical incision. Okay, and now and we infiltrate with some lidocaine, so there's no bleeding. And the next step is you make an incision. That's a number 15 blade I'm using to make the incision. Okay, and then you are exposing the neck. So I'll pause the video. The first step I do over here is to remove all the baby fat that the child has. And if you've done one of these, you'll see children have a lot of fat in this area. So the first step is what we call as a lipectomy, because we have to remove all that fat. Otherwise, that fat will produce a false passage. It will make a false passage. So this is the first thing we are doing to avoid that complication is a lipectomy. So you remove the fat around the trachea. I use a bipolar. You can use cold steel instruments, anything. You pick it up and you remove all the fat. The next step I did was essentially find the midline strap muscle. Like you do your thyroid, you find the midline strap muscle and you move them, retract them on each side. Now what am I doing is I'm putting stay sutures. They are very, very important because if the trach comes out, you can use the stay sutures to pull up the trachea and you can put the trach back in easily. So that's another safety mechanism. The way we put our stay sutures is I'm using a trioproline or trionexor or whatever you want to use, but you have to make sure you get a nice cut through the trachea. Otherwise, it's just going to cut through if the situation arises, the trach is blocked or needs to be removed. So that's placement of the stay sutures. So they are placed in a paramedian position. So on each side of the midline, you'll place the stay sutures, and we actually label them right or left. And the reason we label them right or left is in an emergency, you will end up, everything is rushing, you'll end up pulling and essentially closing whatever airway you have. So everybody knows where the right stay suture is, where the left stay suture is, and you pull it up. Okay, now we are doing our tracheotomy, which is opening up the trachea. And the rings you essentially you do it around second or third tracheal ring. You avoid the first tracheal ring, as we all know, because it can cause perichondritis, chondritis, and cricoid issues. So we do it at second or third tracheal ring. So this is the tracheotomy. Once the tracheotomy is done, this is now the most important step which differentiates adult and pediatric tracheostomy is maturing the stoma. If you do a laryngectomy, it's basically essentially doing what you do at the end stage of laryngectomy is maturing the stoma. This procedure in itself has saved more babies from accidental decannulation and false passaging. So what you're essentially doing is you're suturing the skin to the trachea. So if the trach comes out, where will the trach go if you try to put it back in? It has to go in the trachea because you've sutured the skin to the trachea. So it's not going to go anywhere else. The way we do it is I'm using a porovital suture, and you do what we call as vertical hemimatricing of the suture. So you go through the skin You go through the cartilage, and when you come back, you just come back through the skin. You don't come back through the cartilage again. So it's hemi-mattressing, meaning you're just doing one mattress and hemming in, you're just coming back from the skin. What it does, it covers, the skin actually covers the edge of the tracheotomy, and it forms like a mature stoma. So the stoma which you're going to get 5 or 6 days after surgery, you're actually making it from day one. So that's the very important difference between pediatric and adult. So you'll see how I'm maturing it. So you're using a 4 white pill, you go from the skin, and you put 4 of them, 2 at the top, 2 at the bottom. That's it. You just need to put 4 of them. And you form a nice big stoma over there. So again, yeah.
For pediatric tracheostomy, what type of incision you give on the trachea? It is horizontal, vertical. Do you exercise cartilage or just jaw plaque it to? That part, please elaborate.
Yeah, that's a good point. So we do a vertical incision in the trachea. It's a vertical tracheotomy. You don't need to excise cartilage, and there are reasons, because the adult cartilage is pretty calcified. The pediatric trachea is pretty pliable, softer, so it just opens up. If you make an incision, you pull out your stay sutures, it's going to open up and you can push the trach in. The second thing is the size of the tracheostomy tube is not as big as the adult. The Bajog flap you're saying is the flap we create. We don't do it in children essentially. So because our incidence of tracheocutaneous fistulas is nothing to do whether you make a flap, whether you don't make a flap, it doesn't matter at all. So we've just simplified it at this portion, but the maturing of the stoma, I really want to hammer in because that is very, very important in pediatric tracheostomy. It's not going in my pocket. Okay, so now the next step is we put the tracheostomy tube. So now, what sort of trachs do you use over here, by the way? What sort of tracheostomy tubes do you use in children? The metallic Jackson tubes. They're still used in some centers in US as well. And there's a reason. The metallic Jackson tube, some of the people believe it produces less complications and it's easy to maintain because it's easy to clean up. Yeah, yeah. So metallic tubes are still used in some centers over there. So now we're putting the trach in, and as soon as we put the trach in, we connect the circuit and we flex scope through the trach. And what we are trying to look at is how is it at the carina? Is it main stem where the position of the distal trach is? It should be 1 centimeter above the carina. So 0.5 to 1 centimeter above the carina, the distal tip of the tracheostomy. Because the child is going to extend his neck and everything, and you don't want the trach to get main stem. Okay. So after this, that's the end of the video. I'm not going to go through the video again. We put a lot of padding around the trach. So I know you use a gauze over here. We have different dressings over here. We use a Matrix dressing. We have a silver line dressing. So we use a lot of dressing to avoid wound dehiscence. So make sure you put a lot of dressing around the tracheostomy tube. This is an information sheet which goes on the baby's bedside. And it actually, if you go through this, it says if the baby can be intubated from above, yes or no, because there'll be kids who have subglottic stenosis. The trach comes out and the anesthesia or the neonatologist is trying to intubate from above, but he's not intubatable because he has no airway. What is the brand, size, which type of trach you're using, whether it's a cuff trach or not, what's the inner diameter, outer diameter, and what's the length of the trach, is it a custom trach or anything. And then we also calculate how long the suction should go. Because many of the times, if you go to the NICU, you're suctioning deep and you end up forming a massive lesion at the end of the trach just because of deep suctioning. You don't have to go into so deep. So we measure the length for that and we actually write it on the sheet which goes on the baby's side. And then we write when the first trach change is going to happen, which is a very important thing for the child. We do it at day 5 of the tracheostomy, the first trach change. It's a very elaborated program over there in US. Like we have trach nurses whose only job is to manage trach babies. We have trach protocols everywhere, very detailed protocols about how the trach babies need to get paralyzed and what their sedation is going to look like, what their nutrition is going to look like. But the first trach change is done at day 5 to day 7. Some people do it at day 7. I do it at day 5. This is another sheet which goes on the bedside, and it actually goes through emergency pediatric trach management, like what to do if the trach gets dislodged or if the trach comes out. So what should be the steps? So the first thing is the trach comes out, it's a fresh trach, you just did it, and the trach comes out. You get help, like you get as many help. You have the ENT resident, you call the ENT resident, you have anybody around, you get help. So that's usually done by a nurse in the NICU. You open the child's airway, you tilt the head, you lift the chin, you extend the neck. And if you have matured the stoma, it will be very easy to put the trach back in because you're staring right at the stoma. But if you're not able to put the trach, then we call in a code essentially, and our whole code team comes. And is the airway patent from above? So you look into the sheet and you're like, okay, I can intubate from above. You try and intubate, cover the stoma, and you try to bag and mask. First thing is bag and mask. But if there is no airway from above, you essentially try to put a smaller trach. So from a 4, you'll go to a 3, and maybe I can put a 3 in. If that doesn't work, nothing works, then you end up putting an ET tube through the tracheostomy stoma. These are very intense situations. Like, I don't know if you have ever been to one of these, but this is a make or break thing for any airway program you're developing. If you have a death like that, then people just lose trust in pediatric tracheostomy, will lose trust in you. So we spend a lot of time in educating people about tracheostomy, nurses in the NICU, neonatologists, intensivists, everybody. We sit and have conferences every month, essentially, making sure nothing like this happens and everybody is on the same page. So mature the stoma, very important. This will save you from this situation. It's very easy to put it if the stoma is mature. So any questions about surgery, post-op management, first trach change? I think it's all clear. I think we're going to come for the complications. So there's a huge list of complications which can happen in tracheostomy, and we divide them intra, early, and late post-operative. Intraoperatively, number 1 is bleeding. So you will encounter some bleeding, that's for sure. The thyroid isthmus is very small in children, so you can usually pass through it. You can usually go bleed and it doesn't bleed much. So major hemorrhage is rare in children unless the patient has a high innominate. So whenever you're doing a thyroidectomy or whenever you're doing a tracheostomy, I always put a finger and make sure I feel for the innominate and make sure it's not high up. So that's important once you do a tracheotomy, just to make sure. You'll be surprised, sometimes you'll find a very high riding innominate. Pneumothorax, pneumomediastinum, again, you have to be a really bad surgeon to produce this complication where you literally end up puncturing the lungs. Recurrent laryngeal nerve paralysis can happen if you dissect away laterally, so you strictly stay in the midline. So it's simple management. Esophageal injury can happen, loss of airway, creation of false passage, we discussed, maturing the stoma, and rarely cardiac arrest and death, and those are very sick babies. Early post-operatively, the most common thing which can happen is wound breakdown, and that's why we pad everything. Baby skin is pretty soft, so if you have a plastic rubbing against it, it is going to form ulcerations. So you basically pad it up pretty nicely so it doesn't form ulcerations. And again, accidental decannulation, false passaging, that's very, very common. Late post-operatively is what Dr. Kavita was saying, tracheal granulation, tracheal stenosis, tracheoesophageal fistula, and tracheocutaneous fistula. Have you ever had to deal with a tracheoinnominate fistula? Yeah, it's a once in a lifetime event, but it scars you for a long time. Like, it's pretty bad. So, and you can read as much about it, and these are very good resident questions to ask because this is a life-threatening complication. is how does a tracheoinnominate fistula develop? Because this is one of the things people die of is a tracheoinnominate fistula. Is if you overinflate the cup. So that's why you always have to make sure when you inflate it, whether it's an adult or a child, you have to talk to if you have to inflate the cup, they have to give cup-free periods in between. Like they cannot overinflate it, and they cannot inflate it for extended period. The second area where this happens is the tracheostomy tip, essentially. So the tip can erode, especially in children who have cervical issues. Their tip can actually erode and cause an innominate fistula. The mechanism, as I was saying, one is the tracheostomy has been placed low and there's a high riding innominate artery. And the other is the tip can produce. And what happens in a tracheoinnominate fistula? You have a tracheostomized kids, there's always going to be a sentinel bleed. There's going to be a minor bleeding before a major event. So it usually happens 72 hours and you'll have a little bit of like a half teaspoon of blood come out of the trach. And that should always make you get your thinking is this might be a tracheoinnominate fistula. And after that, it's just going to be a major hemorrhage and the patient is not going to make it. The first thing you do if you ever encounter that is put a thumb in and try to push it and push the innominate artery and try to control the bleeding with the thumb through the tracheostomy. Unless you have cardiothoracic surgery on standby, whoever will help you out, there is no fun of doing that. So you need to have cardiothoracic on standby. You're going to do an emergent sternotomy and essentially clamp the innominate artery for you. These are temporizing steps, like putting a finger in the tracheostomy stoma and essentially hooking the innominate with the sternum. So it's a very bad complication. Look out for sentinel bleed. If it happens, the first emergent step is essentially to put a finger in, and then you intubate from above and inflate the cup of the endotracheal tube so it acts like a stent, and then you call emergently cardiothoracic surgery and they will help you out. Otherwise, it's hard, the mortalities that you have. False passage, we discussed how to avoid lipectomy and stomal maturation. So always do a lipectomy, always do a stomal maturation, and that's going to prevent false passage. Accidental decannulation. This is the worst thing you can do to a child, and you won't be able to save the child if this happens and you can't put the trach in. So what can you do intraoperatively? Again, stay sutures, mark them right or left, stomal maturation. Always do a flexible tracheoscopy or flexible scope at the end of the trach. So you make sure the trach is in the right position and suture the trach in. I suture the trach in for the first 3 or 4 days. And then we remove the sutures once we do the first trach change. And that just makes me more confident like the trach is not going to come out. ICU, you have to work with your ICU to get adequate sedation and mobilization, and then nursing staff should be trained, have a bedside sheet so everybody is aware there's a trach patient over there. Wound breakdown. So this is how we basically pad everything. So there is a dressing below, there is a dressing on the chin. Very important to have the chin padded. You can use any dressing on the upper part or on the chin. And then we also wrap around the neck because the secretions can go back and actually the trach ties get pretty cut. They can cut through the neck essentially. Which trach ties do you use over here? Are those regular like cord? So they can absorb a lot of secretions because the babies are always, and there have been instances where the ties have become thick and because of the dried up secretions and have cut through and caused carotid injury essentially. So keep in mind all the bad things which can happen. I think this is what we have already discussed. There's a lot of dressing around the wound. We use these sorts of dressing. So we have Velcro trach ties. So these are softer ones. We use Duoderm and we use Mepilex dressing. Many of these dressings are available with your general surgery colleagues. You just have to let them know. They use it for burn dressing. You have a wonderful burn institute. I'm 100% sure they'll have these dressings. If you ask them, you should use it whenever you're doing a pediatric tracheostomy. This was the question which you asked, granulation tissue. So the granulation tissue can be around the stoma. It can be suprastomal, like above the tracheostomy. It can be distal tracheal, where it can be at the distal end of the tracheostomy. So if it is, this is the most common which you see, you can just cauterize. We use silver nitrate, we cauterize. We use steroid ointment, like any dexamethasone ointment you can use. Or if it's big enough, you just excise it, do a stomal revision essentially. The suprastomal ones, there are a zillion instruments you can use. You can microdebride them, you can laser them, you can just use a cup forceps and just remove them. It bleeds a lot. Put some apparent pledgets and what do you call it? Xylometazoline pledgets. So one of the things in airway, endoscopic airway, we use xylometazoline, which is atropine. So we don't use epinephrine pledgets in the airway. And the reason we stopped using epinephrine pledgets was there's no control about the amount of absorption of adrenaline intraoperatively, and it gets pretty rapid. And there were instances where the patient went into fibrillation because we just were using a lot of epinephrine pledgets. So now we've used atropine pledgets, which is xylometazoline or oxymetazoline pledgets, because they give the same result without having that risk of AFib or anything. Distal tracheal are pretty hard. If you get one of those, God bless you, because it's hard to reach those lesions. I use a flexible laser to essentially laser these things. These are some of the techniques for suprastomal. You can put a hook through the stoma, evert it, and then cut it. It's very simple. You can use a sphenoid punch. We all have this instrument. You can put it through the stoma and just punch it out. You can use optical forceps, you can use a laser, you can use a microdebrider. I don't like using coagulation in airway. It's a blowtorch, so I prefer to use a laser. And rarely you have to openly resect them. And these are some of the instruments. You put a hook, you evert it, and you cut it. You can use a sphenoid punch, and you can use a lot of other instruments. So again, my go-to tool is the laser. So I just laser the suprastomal granuloma. And it looks great at the end of the surgery. So, do you have laser over here by any chance? So that's something which you should definitely invest in. It's a great tool to have in airway. CO2 is the gold standard. You just need CO2 laser. That's it for your adult laryngology. For it just comes, everything comes with the set. Yeah, so CO2 laser, the one I use and I've used for the last 10 years is the luminous laser, and many centers have it in India. Now what they've come up with is a dual laser where you have a flexible laser as well as a mounted laser, and you can mount it on the microscope as well as use a flexible fiber to use it. I use flexible, but in your setup that might not work because the single fiber is like $1,200. So it's very expensive. So that's why the mounted laser and keeping a flexible fiber just for emergent cases would be the alternative. But I think laser is a must if you want to do laryngology or airway. Coablation, I know many people do it, but I don't recommend putting a coagulator in the airway. You'll cause more harm than help the child. So laser is something which is a must. This is a small baby with a massive granuloma, which we actually resected openly. In smaller children with big granulomas, you can do a simple open resection where you'll just do a tracheotomy and you can see the granuloma right then and there and remove it, and you can suture the tracheotomy back. It's very simple. Suprastomal collapse. So if you trach a child and you at 2 years of age, he comes back to you, you're like, okay, now the child doesn't need a tracheostomy, and I'm going to scope the child, and you find this collapse above the trachea that is known as suprastomal collapse. And if it's severe, or it can be severe or moderate, the treatment of choice for this is either to wait, which I have very little patience, so I cannot wait. So, or we do an airway reconstruction, which is an anterior graft, as we saw the video before was, you just put a costal cartilage graft, that's going to expand the airway, that's going to take away this problem, and you'll be able to decannulate the child. Tracheocutaneous fistulas. The incidence of tracheocutaneous fistula is pretty low. So if you remove the trach, the stoma closes by 3 to 6 months. Like very less than 5% children will develop a tracheocutaneous fistula. And there are two ways of closing the tracheocutaneous fistula, because our parents want their kids to swim. Like they really want the child to go swimming. So they'll pester, they'll be like, we have to get the stoma closed. So there are two ways to close the stoma. One is you excise the skin and then you put stitches in and close it. The other is you excise the skin, but let it heal by secondary intention. You don't do anything. I prefer the second method. And the reason is we have had instances of pneumothorax. If you close the stoma and the child goes into a coughing spell as he's waking up, he's going to rupture one of his lungs and you'll end up with pneumothorax. If you remove the skin and you let it secondarily heal, it's not going to produce a bad cosmetic outcome and it is going to avoid that complication of pneumothorax. So personally, I've seen one of these cases where we did the excision and we sutured and the child can develop pneumothorax a week after surgery at home and comes into the ER with respiratory distress. So my recommendation would be to remove the skin and then just not close it, like just let it heal, put some dressing and let it heal by secondary intention. It's going to be fine. So that's another questions about peds tracheostomy. So we don't do percutaneous trachs in children. Like there's just no fun of doing them. Like it's basically meant to be a bedside procedure in the ICU. And all these, it's very, very high risk in children. So I've never heard of anybody doing percutaneous trachs in children. At least in US, nobody does it. In adults, yes, it's pretty common. The intensivists will do it themselves, the percutaneous trachs, but in children, very, very high risk. So vertical on the skin, vertical on the trachea. And there's a reason. If you do a horizontal incision in a 4 mm trachea, there is always a chance you can cut through the trachea and have like a complete cut through trachea because it's very small trachea. It's not like a big adult trachea. It's a small trachea. Nothing. It's the same incidence, nothing. Vertical, I've been doing vertical for the last 15 years, nothing. It's the same incidence.
I think it was very useful for me. I want comments from the answer.
No, this is, again, I started this program. I know this would be hard to translate into clinical practice from day one, but just having that conversation started, like, this is going to happen in the next 10 or 15 years. Yeah. Yeah. Yeah, maturation is going to help. Yeah, that's one of the most important steps in peds. Yeah, that's a great question. So whenever the child is ready for decannulation and the parents will say, okay, we have a trach, now we want to take the child for decannulation. The first thing you have to do is we do what we call as a voice valve. I don't know if you use a Passimure valve or not, but that's the first step. It's a one-way valve where the child, put it on the trach and you can see if the child is able to breathe or not. If the child is not tolerating a Passimure valve, he's not ready for decannulation. Like if he can't tolerate a Passimure, which is a one-way valve, he's not able to tolerate the removal of the trach. So the next step is you take him for a bronchoscopy. You want to see why is he not tolerating? Is it suprastomal collapse? Is there a big granuloma? Those are manageable things. You can remove the granuloma. You can do an anterior graft and take care of the suprastomal collapse and get the child decannulated. The second, if the child tolerates this, then we do a capping trial. So we put a cap on the trach and we start off with doing them capping sprints where they'll do it 30 minutes on, 30 minutes off, and keep on extending it till the child can tolerate capping for the whole day. The last step is we do a capped sleep study. So we take the child for a sleep study with a cap on, and if he doesn't have any obstructions during the sleep study, then he's ready for decannulation. If he has, then he might need a tonsillectomy or adenoidectomy or some other supraglotoplasty, some minor procedures, so we can do it. So gap sleep study. We actually do sleep studies in almost all the children who need a tonsillectomy. Because we have the luxury of doing. Like, again, it doesn't, those are the guidelines, but that is not relevant in your setup over here because you might not have the space, you might not have sleep studies available.
Sohit, I would really like you to give some insight because everyone is doing flexible scopy, but fees is not very common in our setup. So can you just have some video or something like that in a later part to let us know okay, that how we can incorporate it in our practice?
Yeah, absolutely. I think it's pretty simple. You have speech language pathologists.
Yeah, we have that.
Yeah, but it's, you work with them essentially. So once you spoke the child, you have a child who comes into your clinic with coughing and choking. You scope the child. At the same time, you have the child feed, and you can use a coloring dye, like all the coloring dyes which come in the market, regular coloring dyes, which they put in all the sweets and everything, the green color. Whatever, if he's feeding mom's milk, you can have the express breast milk, put a couple of drops of the green dye in that and have the baby feed if he's smaller. But if he's taking formula or anything, you essentially put that couple of drops because it gives you a little bit of a resolution where the stuff is going. So when you scope it, baby is going to be crying and everybody's going to be crying. The mother is going to be crying. Everybody's crying in that room. And you actually have the child feed at that time. So it's not a pleasant situation, like, but it gives you a lot of information about if the child is aspirating or not, because you'll be able to see the green stuff go into the air. And then the child will cough and then he's going to splutter it out. And if you see that picture, then you start thinking, if it's not laryngomalacia, then it's probably a laryngeal cleft. You'll see the food go from the backside into the airway. And then you take the child to the OR and you essentially suture the cleft. So PEAS is a very important tool in your armamentarium about diagnosing pediatric dysphagia. So it's pretty simple. It's not difficult. Just the coloring agent, you can use any coloring agent. Green. Some people use vitamin C powder because it makes it orange, like the Rasna, not Rasna. Okay. Do you want me to jump to the next talk?
I want my host to answer.
Oh, okay.
Sir, it's been really enlightening. Everything we do, we see here, and sometimes we find those situations very complicating. And you have given a very insightful knowledge in that, and I would like to thank you for that.
No, thank
And-
you. I'm really impressed by the questions which are getting asked and everything. And we have a WhatsApp. So I get WhatsApp messages from across the world about cases and difficult cases and usually pretty responsive. So Dr. Kavita has my WhatsApp number. If you ever have a PEDS airway case, at any time you want to talk about, I'm happy to help. So.
Okay. Okay. Now we are proceeding forward towards the next topic. That is the multidisciplinary management of neonatal airway obstruction.
This is the last talk, and then we have surgical videos.
This is the most important.
So, this is in this only. This is in this. So in exit procedure. Hopefully I have the slides. So this is more. Now we dealt about the bigger kids, laryngomalacia and everything. Now we are going to go into the little babies, the neonates. So this is focused on neonatal airway obstruction. Okay, so the case scenario will be pretty simple. Again, the NICU will call you. I have a kid who's having stridor or stutter. Your first step would be to do a bedside flexible scope. And as you're doing the bedside flexible scope, you'll start going to look right from the tip of the nose all the way to the distal airway. So in the nose, what can go wrong in a newborn baby? He can have piriform aperture stenosis, where the piriform aperture is pretty narrow. He can have pulmonal stenosis or pulmonal atresia. He can even have an encephalocele or a dermoid. And then one of the simple and the most common things which are missed is nasolacrimal ducts. So you'll see a small bulge in the lateral nasal wall in a small baby. And those are easiest to treat, but difficult to diagnose because we usually use the nose to pass the scope. We forget to look in the nose nicely. Then there are craniofacial issues. Kids who have micrognathia, retrognathia, Pierre-Robin sequence, vallicular cysts, kids who have lymphangiomas and teratomas, and then all the laryngeal issues like laryngomalacia, vocal fold paralysis, tracheal issues, complete tracheal rings, and then pulmonary issues. This is an important, and we read it in 6th grade or 7th grade, is the Pozul's law. And this is very important whenever you're managing airway in a child. Like the flow is related to the 4th power of the radius. So if I'm able to increase the radius of the child's airway by 1 millimeter, which is nothing, his airflow is going to increase 8 times. So it's a different ball game altogether when you're managing a small neonate. So how do we evaluate? As we discussed, we'll do a bedside flexible evaluation, and this is a bedside scope. We already know a lot about it. And the second is we'll do a bronchoscopy in the child and rule out any other airway lesion. One of the things which you must have heard about, which is commonly being done, is the drug-induced sleep endoscopy. So we used to do a lot of these in adults. We have started to do a lot of these in children. What you essentially do is you want to see how the child is going to behave when he's asleep. And how do you simulate natural sleep is you give him drugs to simulate natural sleep. We usually do it by giving propofol and then flex scoping the child. So that is going to actually show you the picture why the child is obstructing at night. All of our kids who have sleep apnea undergo a drug-induced sleep endoscopy before TNA, before tonsillectomy, adenoidectomy, just to rule out other lesions which might cause airway obstruction. So this is a comparison of an awake flexible laryngoscopy in a child who presented with airway obstruction. Should I close it? So this was this is the difference between a drug-induced sleep endoscopy and a awake fiber optic. So on the right side is an awake fiber optic laryngoscopy. This looks pretty normal. You're like, why is the kid still obstructing? Wide open airway. You can see the epiglottis. You can see the cords. But then this is his drug-induced sleep endoscopy, and you'll see how much obstruction he has at the tongue level. So it's a lot of retrolingual obstruction, and you barely have any airway. And once we do a jaw thrust, then the airway opens up. So that's the difference between doing a neonatal DICE versus just doing a awake fiber optic laryngoscopy. This is the algorithm we use for managing or diagnosing neonatal upper airway obstruction. Clinical evaluation, we do feeding studies, we do a bedside scope, we do a DICE on these kids, we do imaging if there's craniofacial issues, and then we get a sleep study done in these kids to assess how bad the obstruction is. So we're going to start with piriform aperture stenosis. If you're looking for this, you're going to find it. The issue is we never look for piriform aperture stenosis in a child who's having stutter or is unable to breathe. These children present with a lot of feeding issues. So if you have a mother who comes to you, hey, I cannot breastfeed the child, he's snoring and he just doesn't take anything and he's losing weight now. This could be one of the reasons, piriform aperture stenosis, where the piriform aperture itself is pretty narrow. It's easily fixable. So look for it in children who are not feeding well and are having stutter along with it. One of the questions which is commonly asked, it's more of a exam question, is piriform aperture stenosis is associated with a single central incisor. So if you look at this child, his piriform aperture is pretty narrow and he has only one incisor in the upper incisor. So that's association with piriform aperture stenosis. always get an MRI of the head in these babies because they can have developmental and holoprosencephaly and pituitary abnormalities. How do we manage it? So this is a kid which came to my office, a very scrawny baby, like was on the 10th percentile of his growth, not gaining weight, failing to thrive. You could hear him, he was having a stertorous sound. And this is how he looked like you can see how narrow the piriform aperture is. There's practically no space. So you can medically manage them if the child is not doing that bad. What we usually do is nasal saline suctioning and a short course of Otrivin, not more than 3 days. If you give Otrivin for longer courses, they develop rebound congestion, which is bad. You can use steroid drops. You can use dexamethasone drops in those babies. Again, very low dose, 1 drop dexamethasone on each side, and that is going to take care of this inflammation. So we evaluated the airway fully and make sure the child didn't have any other things. And how do you manage this? It's a very simple surgical approach. What we do is we call it a sublabial medial maxillectomy. So you expose the upper gingiva and you make an incision in the upper gingiva. And we all know when we are making gingival incisions, we don't make it right at the margin. We have to come a little bit on the gingiva. I use the ear instruments, the round knife and everything, because it's a very small baby. I sometimes do them under the microscope because you don't want to create soft tissue issues. And then once you've exposed it, you use your diamond burr, which you use for your mastoids, like a poro diamond burr, and essentially widen that piriform aperture. Simple. You just along the floor and along the medial wall a little. So you go, yeah, lateral and the floor of the. You see the diamond burr, and we are doing a little bit of the lateral and the floor. Again, the concept is you just want to give it 1 or 2 millimeters, and that's it. That's all the game is in a small newborn baby. So you made a hole over here, and then you go and do the same thing on the other side. This is done under the microscope because you don't want to put mucosal trauma, because you'll end up getting bad stenosis if you do mucosal trauma. So it's like lifting your TM flap or something. You're trying to protect the flap as much as possible. It's exactly like that. You drill, you protect the flap, and then you put stents in. So what I usually do is I use an endotracheal tube and use it as a stent and suture it. And we put this endotracheal tube in the nose, an age-appropriate 3 millimeter endotracheal tube, and we basically use it as a stent and suture it. We keep it for a week. We use Ciprodex, the eardrops around the tube, so it prevents inflammation. And after a week, we remove the stents. We take the patient back after a week, debride it, and that's pretty much it. We're done. So the way we put a stent in is you take an endotracheal tube. Again, I'm talking about a 1-month-old baby or a 3-week-old baby. The age-appropriate tube is 3 millimeters or 3.5 millimeters. Let's go by 3 millimeters. You cut the tube. You basically remove the back middle portion of the tube in such a way so only one of the walls of the tube is removed. Exactly like pointilletresia. One difference over here is, in order to prevent the stent from high riding and necrosing the ala, what I do is I put a circumalveolar stitch. So I go through the gingiva into the nose, go through the other side and pull it down and come out through the gingiva. So that's a circle. Yeah, so it doesn't ride up because these kids can develop alar necrosis if the tube is there. So in order to prevent that, you basically pull the tube down by a circumalveolar stitch. Saline and Ciprodex. Yeah, the same ear Ciprodex. So, and this is the baby after a week. You can see the difference, huge difference in the baby, just the weight gain, family, mother is so happy and everybody is happy. So you see a lot of quick differences in kids. Pediatric airway is not like head and neck cancer where you wait and then you have a recurrence after a 10-hour procedure. It's like imaging. You see the results right in front of your eyes. So it's very rewarding and very satisfying to do that. Coronal atresia, again, now we move back. The only thing in the middle is nasolacrimal duct cyst. If you look for it again, you'll find it. We don't look for it, and that's why we say it's rare, but we don't scope all the kids. And even if we scope, we are not diligent enough to look in the nose properly. So nasolacrimal duct cysts are easy to handle. We basically just, we can microdebride them, we can just laser them, we can just cold steel remove them, and that's pretty much it. Coronal atresia, again, very common. You see it pretty often. It can be bilateral and unilateral. And now you know kids are obligate nasal breathers. So if it is bilateral, the kid is not going to survive. Like neonatal kid, failed extubation, obligate nasal breather, cannot breathe through the nose, is not going to survive. But if it's unilateral, it's going to get missed. And those are the kids which are going to present at age 4 in your clinic, with the mom saying, oh, iski ek side ki naak nikalti rehti hai, nikalti rehti hai. And that is probably unilateral coronal atresia, apart from foreign body, as we are told. But always scope those kids. One-sided nasal discharge in an older child is unilateral coronal atresia. But if a newborn bilateral coronal atresia, it's not compatible with life. Like you'll have to do something emergent. This is what is known as a McGovern's nipple. And this was like a poor man's nasal oral airway at one time. What we used to do is we used to take a normal pacifier. We used to cut the end of the pacifier and use a mask, and basically use the ties of the mask to secure the pacifier to the child's nose, to the child's mouth, and that acts like an oral airway. Now we have oral airway. So if a NICU is having issues, you'll put an oral airway and the child is doing okay. And then you intubate the child essentially afterwards. But this is like a poor man's oral airway, which we used to do. Surgical repairs, I think I have a video if I'm not forgetting, but maybe I forgot. How do we repair it? So we all do now transnasal endoscopic repairs. Previously, we were doing transpalatal repairs. I've not done one in a while. We are so good at PES and endoscopic instruments. We have small endoscopic instruments. We usually, what I use is, we have these urethral dilators. I don't know what is used over here. And we put the urethral dilator through the floor of the nose. It's very, very important to put it through the floor and make sure the tip is not pointing up and pointing down, because if it's pointing up, you'll just open up the whole skull base. So you go down, you put an endoscope through the mouth, use your normal mouth gag, open this, put a 120-degree endoscope through the mouth, so you're looking up, and then you put the dilator through the nose, and you'll be able to see it come out through the mouth. Once you've made that opening, then you can use a microdebrider, or you can use cold steel instruments to remove that. And always do a posterior septectomy in these patients. So use a backbiter, the same PES instrument, you go back and remove a chunk of the posterior septum. Pretty much that's it. Yeah, the posterior septectomies, it will save you a lot of issues, like and it's simple. The backbiter, which we use in PES, you just go back, you rotate it, you hook it to the back and take 2 bites, and that will open up, give you a massive space in the back essentially. So posterior septectomy with endoscopic opening. It's again, not a complicated procedure, but you have to bring them back again and debride it. You have to do it 1 or twice. Inject steroid. It's the same. It's a scar. You treat it like a scar tissue. Inject steroid. I sometimes balloon dilate it. It should be age appropriate, meaning you should be able to pass an endotracheal tube, which is age appropriate. Age appropriate endotracheal tube. So one of the tricks one of my anesthesiologists taught me when I was training is your size of your pinky finger is the size of your subglottis, is the size of your piriform aperture, is the size of the quena. So he used to always measure that size of the tube is going to intubate with the size of the pinky finger or the little finger of the child. So if that means all this is age appropriate. So if you can pass an age appropriate endotracheal tube, that's appropriately sized airway, essentially. So look at that little finger of the child. Okay. Well, we talked about laryngomalacia. It's the same. One of the things which I can Can I escape from this? I want to run this video faster, so. Can I escape and go back to this talk? Is it still getting shared? No. Okay. Okay. That's. It is, again, it is going to, it's happening. If you go to, in India, and now everybody is specializing, some people are just doing head and neck, some people are doing otology. It is going to happen in the next, that's what I'm saying, like, it is going to happen in the next 10 to 15 years where we'll have fellowships for, there are fellowships for head and neck. There's so many fellowships. When I left, there were hardly 1 or 2 fellowships in head and neck. There's so many fellowships in head and neck, so many fellowships in otology. So this is going to happen. And then in the next 20 years, there will be dedicated pediatric hospitals in almost every state. And then PCNT is going to be like the main thing. So it's just a matter of time. Yeah, but it's going to increase. Like 10 years ago, 15 years ago in US, that was the same number. There was hardly anybody doing it. It's such a new field, but it's going to happen. And in India, the difference is parents love their children. Like they'll do anything in their power to have a child survive the child. So
The only treatment for subglottic stenosis was putting a tracheostomy, and since it was not resolving, some of the other surgeon was closing it, and then we used to lose the child. So this approach of subglottic stenosis management needs the most attention now,
absolutely, yeah.
because that is again misdiagnosis, and you're not able to diagnose, so you close the tracheostomy that like now the function is okay.
So the way you start is first is getting good at doing a pediatric bronchoscopy, and that wholly solely depends on training anesthesia, wholly solely. Like I have been in all different places, and I always, the starting point of anything is you have to have trained anesthesiologists who can, and it's an art, it's the literal art of anesthesia is pediatric, and it's not, it's a full art. Like I'm amazed at some of the anesthesiologists, they'll have a kid spontaneously breathing, and I'm doing an endoscopic laryngeal cleft repair, which takes me 1.5 hours, and the kid doesn't even buckle or anything, nothing happens, just smooth anesthesia. That's an art, like managing that exact level of propofol or Presidex or whatever you're using to have the child and let him do what you want to do. It's an art. So that's the starting point is, and you have to go and learn it. Like you have knee gum hair, you have to go and learn from people, like how do they do it? I'm happy to share my protocols, what my anesthesiologist uses. We use propofol, Presidex, and sevoflurane for just spontaneous breathing. And that's, yeah, and then we topicalize the airway with 1% lidocaine or 4% lidocaine, and then don't give a propofol bolus. Like some of my anesthesiologists love to give a bolus from the get-go, and then the child goes into apnea and you end up intubating, and then you land up in this cycle. We titrate it. We have a running drip of propofol to give a little bit at a time. Some people give ketamine at the start. Again, it's very anesthesia dependent. But that's simple. Those are 3. If you have SIBO over here, like I've been to India where some centers don't even have SIBO. Yeah, so there are centers in India that don't have SIBO. So they are like, oh, what will we do without SIBO and all that stuff? And I don't know, but that is what we use over there. So you have half the battle. You have half the battle won. That's the whole point. No, that's the half of the battle won. Like if you have good anesthesia, supportive anesthesia, who don't shy away from these cases and like to do challenging cases. These are challenging cases. These are not like your. Yeah, that's wonderful. No, that's great. We don't use jet ventilation in children. Most of the people. Simple thing. What you can do is we can put a nasotracheal tube and just keep it in the pharynx and give like 100% oxygen. And that is another, yeah, just insufflation through the nose. Like that's another way of doing it. Like if you don't want to completely deprive the child of any airway. So this is a technique which we've developed where I come from, and it's basically used for epiglottic prolapse. I don't know if you have seen patients in which the epiglottis just prolapses into the airway. There are ways to do it. You can either stitch the epiglottis endoscopically, which becomes a little bit challenging, but then you can also stitch it from outside. So what we essentially use is we put a needle through the neck with a looped stitch in it. So this is a looped stitch. And we put a needle through the neck, we pass it through the epiglottis, essentially. You can see the loop in the thread. And once this is passed, we basically pull it out. And then we put another thread, another needle with a single thread in. And we use this loop thread to essentially pull that single thread out. If you ever have a case like this, let me know, because I'll send you my paper on this. It makes it very much easier, and you basically put that stitch and it keeps the epiglottis in place. So it's known as transcervical epiglottopexy. Wonderful question. So the paper I published 8 years ago was about epiglottopexy and swallowing. I was surprised. I was like, why aren't they aspirating? Like the kid next day, he'll be feeding like a champion. And I'm like, it's unbelievable. We overestimate the function of the epiglottis in swallowing. There are various levels in so your false cords go close, your true vocal cords close, your AE folds come together, and your epiglottis comes together. And I've done epiglottectomy in children, like where we'll just cut off the epiglottis and still they don't aspirate. So I think the epiglottis is overestimated in pediatric care, but that's a valid point. Like they don't, in my hands, what I've seen, they don't aspirate. You don't produce neoaspiration. Other common causes will be microgonathia. And again, you have a whole army of Pierre-Robin babies, which you'll see. And you can have Pierre-Robin, Stickler, Trichocolins, hemifacial microgonathia. We have a very robust craniofacial center. So this is essentially the same sleep endoscopy I showed, where you see significant retrolingual obstruction. And now we'll do a jaw thrust. So you can very well appreciate if the child gets a little bit of a jaw extension, his airway is going to open up. So how do you manage retrolingual obstruction? So there are a couple of ways of managing. So if the child is doing fine, conservative management is simple. If it's not significant, you can have the child do prone positioning. Put a nasal trumpet in, and you can do a nasal CPAP nowadays. The treatment of choice now is mandibular distraction osteogenesis. Like it's getting pretty common now. We distract the mandible essentially. It's a very, very simple procedure. You expose the mandible, you cut the mandible, do a mandibulectomy, and then you essentially put the distractor in. You rotate the distractor and increase the length 1 millimeter every day. You distract it for 6 days and then remove the distractor in 2 months. So it's pretty simple. So this is a bilateral vocal fold paralysis is again something you might see commonly. And it's important to know a little bit about bilateral vocal fold paralysis. Same story, NICU calls you, we have a kid who's having stridor, newborn, absolutely day 1 of life or day 2 of life. And we have stridor in this newborn. You scope the child. What is the next step? You do a flexible scope in the child and you see the cords are not moving, like both the cords are stuck. The child does not have a history of intubation, because if the cords are not moving and the child has a history of intubation, you have to rule out cricoretinoid joint fixation. So the child doesn't have, you make a diagnosis of bilateral vocal fold paralysis. The question for residents is always do an MRI of the brain in these children, because they have an Arnold-Chiari malformation, which if corrected, you have a neurosurgery department, I'm pretty sure they must be doing peds neurosurgery, which if corrected, will actually help, will resolve the bilateral vocal fold paralysis. So newborn infant, not breathing, flexible scopes, bilateral vocal fold paralysis, MRI brain, rule out Arnold-Chiari. If it is present, consult neurosurgery, decompression will improve. But if the child is not having Alnott carry and the child is not breathing well, then what are the steps you can do? Okay. So you can see this is a awake fiber optic laryngoscopy in a child with bilateral vocal fold paralysis. The cords are not moving. It's pretty static. That's a diagnosis of vocal fold paralysis. There are various ways of doing it. I'll just focus on two common ways we manage it in a neonate. There are like a zillion ways to do it and how I do it. One is known as an anterior posterior cricoid split. It's the simplest thing you can do in life. These names sound fancy, but they're not at all fancy. They're very simple. This is what we have done is we suspend the child again with wonderful anesthesia because you see the child is not intubated. You cannot do this with the child intubated. And I've exposed it with a vocal fold spreader, okay? And you use a sickle knife, like a regular laryngeal sickle knife. And you essentially, with the suction tip, I'm giving some pressure and you make an incision in the posterior cricoid. You make an incision in the front of the cricoid. You put a hand on the baby's neck, give some cricoid pressure. You see the cricoid, you just cut it. So basically, you're splitting the anterior and the posterior cricoid. You put a balloon in, or you can use an endotracheal tube as well, but put a balloon, dilate it, and then intubate the child. And after 3 or 4 or 5 days, you can extubate the child. What are we doing with that split is I'm giving half a millimeter in the back, half a millimeter in the front, 1 millimeter I'm giving the child in total. That's going to get filled up with scar tissue in 4 or 5 days, and his airway is going to get bigger and you won't need to trach the child. So anterior posterior cricoid split is a very simple procedure which you can do. Yeah, absolutely. Very soft. You can very easily cut it through sickle. You see the split in the back wall, and now that's the split in the front wall. So the issue with this surgery is, and the reason I don't do it anymore is 50% of the kids with bilateral vocal fold paralysis don't require anything done. Like you can send them home and nothing bad is going to happen to them, except when they get sick and they'll come back to you. But 50% have severe airway obstruction, and you have to do something about it because in 1 year's time, 80% of the kids with bilateral vocal fold paralysis will get movement back of their cords. So you don't want to trach a child when you know it's a temporary thing. You trach a child, the trach stays in for 4 or 5 years, and his whole childhood is messed up. His family's life is messed up. It's just mind-boggling if you tell a mother, oh, you have a trach baby, you have to suction it regularly, you have to change it. It's a nightmarish situation. They don't sleep for 5 years, essentially. So you always empathize with them. That's why I feel bad. I have heard people who trach for laryngomalacia. Like there was a time we were traching for laryngomalacia. And that is like, you can't even think of in today's world, like a simple snip, you can improve the child's airway and you were essentially traching a child for this. So this is one way of doing it. The other is suture lateralization. And this is my preferred way of doing it because you don't have to keep the child intubated after split. You can do a suture lateralization and essentially send the child home the next day. And how we do suture lateralization is the same way I showed you for the epiglotopexy. So I have a needle, I put it from the neck into the larynx. It has a single stitch in, we pull it out, and then we put another needle a little bit above it with a loop stitch in. We pull the loop stitch out. I put the single stitch through the loop stitch. You see the single stitch going through the loop stitch, and then you pull out the loop stitch. So the loop stitch is essentially meant to get that single stitch out through the neck. It's simple. It's not complicated. And we tie it with this elastic button in the neck, so it doesn't cut through into the neck. So this is where the needle goes. Again, the thyroid cartilage is a little bit lateral to the midline. Thyroid cartilages are not calcified. You can easily pass the needle. In adults, if you have to do it, you actually go to the cricothyroid membrane. But in children, you can very easily go it through the thyroid. And this is how it looks like. Like you pass a single suture, you pass the loop stitch, and you've lateralized it. This is all the space the child needs, and he's going to be a happy camper, and you can send him home without a trach, essentially. You bring him back every 2 weeks. You scope the child. You see if the cord function is coming back. If it hasn't come back in 2 years' time, then you go for more definitive procedures, which is like a posterior cricoid split and placement of a graft. But this is, I'm just talking about simple stuff. Like this is something which we can do. Like this. It's actually proline because we want the stitch to stay. So it's the permanent suture. So you can use nylon, you can use silk. Proline is, if you have proline is the best to use. So we want something 30 to 40, depending upon the age of the child. Like if it's a 30 would work fine. It's a very good technique. Simple. You don't need expensive instruments. It's very simple. And this is how the procedure looks like. This actually, the child actually had a supraglotoplasty. So this is the loop stitch through the neck. We pull it out, and then we are going to put another needle with a single suture, and then I'm going to pull this out, and it takes away with it the single stitch, and then you can lateralize. So endotracheal tube related trauma. So we discussed a little bit about it, but this is more about how to medically manage endotracheal tube related trauma. So this is how it looks like acute lesions, like the NICU extubates a child, has stridor. This is how the airway looks like, pretty bad, or it could be a small web which is formed. So what do we do about this? As I said, we can topicalize and put a plug of Tobradex at the end. Simple procedure. You can start antibiotics, steroids, and when you extubate the child, you give more antibiotics and steroids. And 8 out of 10 children will start tolerating extubation after this. This is a miracle drug in airway. Use it generously. Ciprodex, like we use it after airway reconstruction. We use it for stenosis patients. We use it for almost anything in the airway. We use it as a nebulized form. 3 drops and 3 ml of saline, and you can nebulize it, and it does wonders for the airway. So, thyroid ALA we discussed, but if you don't want to do a thyroid ALA, a simple was an anterior cricoid split. You can do it endoscopically as well. Previously, we used to do it through the neck. It's pretty simple, and that thyroid ALA we have already discussed. Same with the posterior cricoid split. You can do an endoscopic. We showed that videos. This was more about thyroid ALA, and these are the indications, like 2 failed attempts. You have documentation of stenosis. Should be a little bit heavier child, could tolerate spontaneous ventilation, and doesn't have major cardiac issues. So we saw all this. Complete tracheal rings. I don't know how commonly you're going to see, but that's a rarity in which you don't have the cartilage segment developed in the trachea, and it's actually the muscle, trachealis muscle developed, and you have full tracheal rings. And these patients present with severe stridor. And this is more for very advanced airway where you're doing slide tracheoplasties and everything. Okay, and I'm going to talk a little bit about exit procedures, how we do it, and how we manage and questions about neonatal obstruction. These are the common things: failed extubation attempts, vocal cord paralysis, piriform aperture stenosis, guanal stenosis. I think. Yeah. Perfect. Okay, so we're going to talk a little bit about exit procedure. So what exactly is an exit procedure? It's an acronym which stands for ex utero intrapartum treatment. And what essentially it is, and we'll break the definition down into various things. Where is a procedure whereby prenatally diagnosed patients. So prenatally diagnosed means your mother is pregnant, comes for a routine ultrasound, and you see the baby with a neck mass or a baby with a micrognathia. So those are the 2 common situations you're going to see. So they get prenatal ultrasounds done. So you have to, it's a prenatally diagnosed. So diagnosed on routine ultrasound with airway obstruction. So of course, what are the 2 common causes of prenatal airway obstruction? Would be micrognathia or a neck mass, a big neck mass which is compressing on the airway. Undergo partial delivery. What do you mean by partial delivery? Partial delivery means the child is not delivered completely, still attached to the mother with the umbilical cord and maintained on placental support. So he's getting oxygen through the placenta rather than you're clamping the umbilical cord. Undergoes airway instrumentation to secure the airway. So while he's attached to the mother with the umbilical cord, you do airway instrumentation. Either you intubate the child or do a tracheostomy before completion of delivery and umbilical cord clamping. So before you cut the cord or deliver the child, you do all this instrumentation. while the child is on maternal placental support. So why do we do this? So imagine if a child has complete airway obstruction, has micrognathia, and he's not going to breathe. You don't have equipped ENT people around to do a trach. You're not prepared for an intubation or a difficult intubation. You clamp the cord, the child has no airway, nothing, and he's not going to make it. But if you keep him on placental circulation, you actually buy in 45 minutes, up to 30 to 45 minutes of time before something bad happens. So that 30 to 45 minutes is a eternity for us to actually have an airway, whether a trach, whether an intubation for the child. So that's the whole concept of an exit procedure. So when do we do an exit procedure? So number one is, it's known as exit to airway, exit to resection, exit to ECMO, and exit to separation. So we'll just focus on exit to airway because that's where ENT comes into play. So airway wise, it could be an extrinsic compression of the airway, which is a teratoma. Most commonly, you'll see a big neck mass in a baby. The OBGYN did an ultrasound. Oh, there's a baby, but what do I see? This is like a big neck mass. What do you do next? You get a fetal MRI, and in the fetal MRI, you'll see a big neck mass. It can either be a lymphatic malformation or teratomas. Teratomas bleed into themselves. Very important. If you ever make a radiological diagnosis of teratoma, it's an automatic exit procedure, because even if it's small and you attempt a normal delivery, then it can rupture and bleed and cause an acute airway. So teratomas are automatically an exit. Lymphangiomas depend on the size and on the level of airway obstruction. And then severe micrognathia. If the child doesn't have a chin, he's not going to be able to breathe, and that qualifies as an exit procedure. There is a rare entity where the larynx is not developed. We call it laryngeal atresia, and that is known, that goes by the acronym CHAOS. Like, I love these acronyms, exit and CHAOS. So it's basically congenital high airway obstruction. So you don't have a larynx, like larynx didn't develop. What will you do in this case? Like, child is not being able to breathe. So you have a team which comes in the exit. It's a massive undertaking for the whole hospital, essentially. Everybody in the hospital, it's a once in a life, it's like Kumbh Ka Mela. Once in a lifetime affair, but everybody comes together in the hospital to prove a point, like we'll save this baby, essentially. It starts off with, and you are the focal point of this whole Mela. If you walk into one of these rooms, there'll be 60 people in the room. And that's why you have to plan them pretty meticulously, and planning is the main issue. And everybody has a role assigned. What is the role of the ENT? What is the role of the OBGYN anesthesiologist? The anesthesia for this procedure is different from anesthesia for C-section or a cesarean section. It's very different. So you need to make sure the anesthesiologist is aware. Neonatologist is there. Of course, they have to be present. They sedate the child, do all this stuff. We are the people who run the show. We are going to secure the airway in the child. Anesthesia has their roles. Everybody has their roles. We talked about indications, criteria for exit. So it's important to make a decision about which patients want an exit, because it's a massive undertaking for the hospital. So teratoma, as I said, if you do a prenatal MRI and the child is diagnosed with a teratoma, you'll do an exit. Any mass which is greater than 5 centimeters. If the mother has polyhydramnios, that means that or absent of fetal gastric fluid, those are signs of severe upper airway obstructions, and signs of intrinsic airway obstructions like hyperexpanded lungs or flattened diaphragm. So those are the criteria for doing an exit procedure. We talked about lymphangioma. Micrognathia is one of the things, and again, once we do a fetal MRI, they can calculate what we call as a jaw index in a child with micrognathia. And if it's less than 5th percentile, that qualifies for an exit procedure. Or if you have evidence of glossoptosis or anything. So this is a patient, like this is the ultrasound. You can very well see the kid has micrognathia. It's a slam dunk. Like, this kid will not be able to breathe when he's delivered. So this qualifies for an exit. This is a fetal MRI. Again, you can see complete absence of a jaw. And this is a 4D ultrasound. So you can also see the kid has some ear anomalies and must be a syndromic baby with no jaw whatsoever. Same, another baby. This actually had no jaw, it's agenesis, complete absence of the mandible. And again, you can see the glossoptosis, complete obstruction of there's no airway shadow in the fetal MRI. So this kid will need an exit procedure. So this is how we do the exit. So this is one of the photographs. You can see we do a C-section, first of all. We deliver the baby out and it's still attached to the mother with the umbilical cord. And then you end up doing a tracheostomy with the child attached. We attempted intubation, but the child was not intubatable. Severe micrognathia. You can see the child has no jaw whatsoever. And then we actually did an exit to tracheostomy. So while the mother was attached to the mother, we did a tracheostomy in the child. And this is how he looks like after the tracheostomy. By this time, he had mandibular distraction and now he's decannulated. It's a different story. But this was a child who would not have made it, like he would not have survived essentially for an exit. So that's where a multidisciplinary airway team comes into being. You have pediatric ENTs, pediatric pulmonologists, neonatologists. Peds ENT is all about multidisciplinary approach. You cannot do it by yourself. It's not like ear surgery or like, it's like cancer surgery where you need everybody on board and even more people on board to do anything peds related. So that's it. Questions? Excellent. I think we're on time, 12:40.
Thank you, sir. Very, very interesting talk. Got to know about exit. That was really very interesting. Sir, I would request the audience if anybody has any questions. Residents? Thank you very much, sir.
When you told that you will be discussing exit, so really it was something new topic for all of us because we have never thought about it. Difficult airway we know, but a joint approach to tackle it, I think it is our future goal now. We should think about it now.
Need like extensive equipment. What you
Right.
essentially need is, and it basically sets you as a center where you do complex things which nobody else wants to do. And that's what you want to become. You want to become a place where you do things which nobody else wants to do. That's your objective in life. Like otherwise, what will become a big center, like an academic place? And these are the things which make you do. I think people realize that. And it's very simple. If you pick up any trial, first of all, people need to know there is a management. I'm pretty sure many of these women who are diagnosed with, they get ultrasound done during their pregnancy. And they must be diagnosed with neck mass or something. They must be told a severe thing, like there's nothing we can do or something, because they don't even know there are options where we can save the child. I've done massive neck resections and people with babies and given them a normal and be like, so talk to your OBGYNs, like they will definitely do a talk and exit with them. That's how we started where I started, like talk to the OBGYNs. Once they were picking up, they'll send us the patients. And then you talk to your neonatologist, hey, we are going to plan an exit. Talk to your OBGYN anesthesiologist, OBGYN people. Develop a team. It's basically intubation. It's a typical intubation. So you either do intubation to the mouth, or you can do a fiber optic intubation. If that fails, you basically do a trach in the child. So it involves a lot of training you need, but it's doable.
So to audience, I'll tell you, this laryngology topic is very challenging. Maybe I'll take 5%, but the youngsters who are sitting, they will evolve into 30–40% of this pediatric laryngology, and that is our aim to conduct this workshop to get directions. So I want all youngsters to interact with him, how to, if you are interested, how you should develop or get trained to that. So don't lose the opportunity. We are having 10 minutes break, so our speaker will have some rest, and then we'll have all videos related to cricotracheal reconstruction, laryngeal cleft, and their preparations. So Sir, can you please put the last slide you have put for exit? We are having press people, so it will be easy for you to explain the exit plan for them. The same, yes. Or you trying USG. This is okay, sir. So, thank you. Another slide is there in which the USG was done. More explanatory. Yeah, this is better. And thank you all for coming. All of you are invited for dinner. Please. एनएससी पीछे आप भी आइए ये भाई दो पीछे का है
is done. Reading in the books, it is different, and the way you showed it, it was very nice. Thank you so much, sir. Hope it was a good experience for you also. Thank you so much. I would like to request Dr. Kavita Sachdeva ma'am to kindly felicitate Dr. Ashish Sethi, sir. Okay. Thank you so much, sir. Sir, आप तो support का एकदम pillar है. No, sir, you've always been like that. Thank you so much, sir.
बिना एनेस्थीसिया के हम लोग कुछ नहीं कर सकते। अगर ये नहीं करना मतलब नहीं कर ये हॉल में सर करेंगे सर से हम लोग सर करिए और हम लोग को ले लेते हमको सर का इंटरव्यू देंगे next time we come, people surgical.
Good afternoon, everybody. Now we are going to start the online surgical video sessions. Yeah. So, everybody sit back and enjoy, please.
Okay, so I think this is the last session for the symposium. And this is more of just the surgical videos. It doesn't come close to doing live surgeries, but it's much more time efficient and it's much better learning if you look at the videos rather than going through the setup and everything, which are live surgeries. Yeah. So I've divided it into two. As far as one, we are going to do endoscopic surgical videos, and then we are going to do one video of open airway surgery, which will be a LTR. So we'll start with endoscopic airway surgery. So the first thing is to understand how the room is set up in the OR. This is a standard setup in the OR. You can see the patient is lying on the table. The surgeon is sitting at the head of the table. Anesthesia is to the right. The instruments are to the left. We're using a microscope and laser. The laser is to the right. And then we're using a microscope to do the surgery. And this is like a schematic of how the setup looks like. The baby is here, surgeon is here, laser is here. And then the laser operator is here, the trainee is here, anesthesia is to the left, right, and then everything is to the left. So this is how the OR room looks like over there. And then next, we're going to talk about how we position the patient for these surgeries. We saw something in the RRP talk. So in this case, I'm using a Lindholm laryngoscope. So you go in with the Lindholm laryngoscope. The Lindholm laryngoscope actually has two side ports. One is used as a light source. The other is used for insufflation. So you can cut a 6-number endotracheal tube, and anesthesia can connect the circuit through this through this port so that they can do insufflation. And again, we suspend the child on this stand, and I've used a little bit of a cricoid pressure using the tape, a generous shoulder roll. This is a laser case, so we are actually covering the eyes with wet gauze. And eventually we've covered the whole face with a wet gauze for our laser precautions. So this is the whole setup for the patient. So we are going to look at some of the supraglottoplasty, how to do it, what are the tools we use. As we all discussed, there are 3 types of laryngomalacia. One is floppiness over the retinoids. You can see very simple. And then other is tight AE folds, where the area-epiglottic fold is pretty tight. And lastly is a complete epiglottic prolapse, where the epiglottis is completely prolapsing into the airway. So let's start off with type 1 laryngomalacia. And so once you have suspended the child, and again, this is a laser video, you can actually use cold steel instruments as well. So you use a standard grasper. You'll hold the floppy tissue with the grasper, and you make a cut with the laser superiorly. You see, I made a superior cut in the AE fold, and you lift up that redundant tissue, and then you go around removing that redundant tissue. So the laser I'm using is actually the ultra pulse laser in a mode which we call as ultra pulse, and it actually gives you a very nice cut. There's not much charring, and you can actually zap through these lesions pretty nicely. So always underdo your supraglotoplasties. You don't want to produce suprastomal stenosis. That is the worst thing you can do to a child. If you are pretty aggressive, you'll end up producing supraglottic stenosis, which is practically, there's no major treatments for this. And this is, we are doing the other side. The trick in this is to leave some mucosa in the interarytenoid region. Don't go in the interarytenoid region. Just remove the redundant tissue. Always avoid the interarytenoid region. So that's the trick. Another case, you can see how bulky the arytenoids are, and in this case we're using cold steel, so it was a little bit bloody because this is an inflammatory disease the child has. This was a different pathology, but you can just hold it with a grasper and use scissors, curved laryngeal scissors, to essentially cut that floppy tissue. Type 2 laryngomalacia. Okay. So tight A folds. Yes. If it happens, you have to intubate. Like if the saturations go down, that's where anesthesia comes into place, is their skill of being able to maintain the child and spontaneously breathing without the need for intubation. So how will you anesthetize a child? Like you can either put a tube in and then you paralyze the child or deeply sedate it, but then you won't be able to work around the tube. You can do it, it's going to be hard, and you won't know how much tissue you have resected. The other way is you get them in a plane where they're able to breathe, but they're deep enough for you to operate. And there are two ways of doing it. You'll topicalize the airway as well, so they don't spasm. And secondly, anesthesia manages the drug in such a way that the child doesn't get apneic during anesthesia. If it gets apneic, suppose they give more propofol and the child goes apneic, you have to intubate. And you'll do intermittent intubation at times, you have to do it. So it's not like a all or none, you can always intubate. Absolutely. And that has happened to me. That's why I use the laser. I used to do cold steel. And then one of the babies we were doing actually aspirated blood, and he was a complex cardiac baby. He had laryngospasm because he was not deep enough. And then he ended up in an arrest. We had to intubate him and went to the NICU. Everything turned out fine, but it can happen. But with laser, that's the reason I use laser. It's pretty, you saw there was no bleeding in the laser case. Okay, so this is type 2 laryngomalacia. Okay, so very tight AE folds. So same thing, you hold and you're lasering the AE fold. So in this case, we're going to release the AE fold. I'm going to stop the video. So you can see I release whole of the AE fold all the way over here. So AE is your epiglottic fold. And if you look at this fold, this is known as the pharyngoepiglottic fold. You see this fold? This is the pharyngoepiglottic fold. You're not supposed to go through this. This will produce aspiration. This is the epiglottic fold. So you basically lyse this area. That's pretty much it. You can use scissors. You can just make a cut, and that will take care of it. People recommend taking a wedge of tissue over here just because it doesn't re-scar back. It's hard to do that in small babies. Just snipping sometimes helps rather than taking the whole wedge. The key is never to go in this area, the interarytenoid area. Like if you end up demucosalizing the interarytenoid area, it's going to form posterior supraglottic stenosis for sure. And it's a very hard condition to manage. So the trick is lyse this, and that's pretty much it. Use afrin pledgets or otrivin pledgets to control the bleeding. And that's pretty much it. You don't need to intubate the child. Some people intubate for one night. I don't. I just keep them extubated and send them. I've never had to intubate one of my suprachoroidoplasties. But if you're doing them new, intubate because they can swell up. Post-operatively, they get 3 doses of steroid and they continue the reflux medication for some time, at least 3 months. And this is how it looks post-operatively. So very nice, wide open airway, nothing close to what we started off. So it's very simple surgery. It's not a complicated procedure. This is a case where we had both type 1 and type 2. So tight AE folds, as well as you see there's a redundancy over the arytenoids. So it's both type 1 and type 2. And what you essentially do is the same procedure. We're going to hold the floppy tissue with a grasper. This is known as a heart-shaped grasper. It gives you a little better grasp of the tissue. You laser through the AE fold, you lift up the tissue, and then you laser through rest of the. So you see there's not even a drop of blood which comes out if you use the laser. So, and you just keep on going until you get that floppy tissue. Again, don't overdo it. Try to be conservative in your management. And we end up doing the other side. So you can use same with curved scissors. Curved microlaryngeal scissors will do the same thing for you. Good. And these are the small pledgets we use. These are afferent pledgets. This is how it looks post-operatively. Yeah.
Scratches around it, and then it will heal. So how will we follow up the healing process, or what should be the then?
Yeah. So for suprachoroidoplasty, it's pretty simple. You do the surgery, you call them after a month, you scope them in the clinic, and it must have healed by that time. They continue reflux medication for 3 months. You'll see a huge difference. Their weight gain goes up. As soon as you remove or snip that up, the tissue, the weight gain is going to go pretty much.
Okay.
For a laryngeal cleft, once you've repaired the laryngeal cleft,
Right.
you always have to tell the patient it's not like a quick fix. It takes at least 6 to 8 weeks for the dysphagia to improve. So we do a repeat swallow study in 8 weeks. You do a swallow study preoperatively, you do a repeat swallow study in 8 weeks.
Okay, and then in the meantime, the child is feeding by a Riles tube?
By a Riles tube, or some children already have G tubes placed in, or a PEG tube. But you keep them on an NG tube or a Riles tube for that time. And once the swallow study is good, you remove the Riles tube.
Right. Okay.
But a swallow study is definite in 2 weeks, 8 weeks. Don't do it before that because the child will still aspirate. It takes 6 to 8.
Okay.
So any questions about suprachoroidoplasty surgery? So pretty standard, a Lindholm laryngoscope, grasper, curved iris scissors. You basically need 3 instruments for doing that surgery. Okay. Laryngeal cleft. So this is a kid, chronic aspiration. Sorry, I'll pause. 2-year-old child, chronic aspirator. Mom says coughs and chokes every time he feeds, has been doing it for a while. Do a swallow study, shows aspiration. The child is frankly aspirating. You take him to the operating room, you suspend him, and then you probe the region and you find a cleft which goes to the vocal folds. So there's no interarytenoid muscle. So that's a laryngeal cleft. There are 2 ways of doing it, and it's basically 2 mucosalized surfaces, and you want to connect them. So you're going to make them raw. You can use laser, you can use cold steel, and then you basically need to stitch them. But there's a technique to stitch them. It's not an easy thing. So I use laser, so I'm lasering the interarytenoid area, and I'm lasering the muscle a little bit. So we literally have to form a raw area, and then I put a stitch in. So if you look at the stitch and the grasper, I'm using what we call as a laparoscopic needle holder. So if you have general surgeons who do laparoscopic surgery, you can ask them for a laparoscopic needle holder. they have pediatric size laparoscopic needle holders, and you use a 4 vicryl suture. And it's a difficult stitch, so it's not an easy stitch. We actually have our residents practice on pig larynges or something before we actually have them do the surgery. So use a 4 vicryl, and you basically go back from your left. The knot has to be on the pharyngeal side. So you go back through one side and then come out through the other side. And with that set, there is a knot pusher. So you cannot put your finger all the way down to the larynx. So you need to have a knot pusher. And again, it comes with the laparoscopic set. You can push that knot all the way down. So I took out the needle from one side. Now I'm going to put it on the other side. The endo-wrist movement is pretty difficult in the larynx, but over time you'll develop the technique. And then you tie the knot outside, and then you'll see the knot pusher, and you can push the knot all the way down. Usually 1 or 2 stitches suffice. You don't have to do multiple stitches. It's a type 1. If it's a longer type 2 cleft, then you need. This is the knot pusher. It's basically a hook which is long, and you can just go in and tie the. It absolutely does. So what we do at the end of the surgery is do a supraglottoplasty. We release the AE folds actually to give more airway. Over time, you get so good at it, you really know how much you want to close. But initially, you will struggle to gauge. It's a judgment comes with experience, like that cannot be taught. So once you put the stitch in, you have to release the AE fold to give more space. Some people will have stridor after this. So, but it's temporary stridor. So you see, I'm singeing the knot down and then I cut it. And make sure you don't cut it, leave a long knot because the child is going to cough if it is super. And now I'm going to release the AE fold. So you basically just release the AE fold on both the sides. Like simple release just to get more airway. And that's how it looks at the end of the surgery. So, but it takes 6 weeks, 6 to 8 weeks to show an improvement. So this is a case of suprastomal granuloma. You see a massive granuloma. Pretty simple. I use laser. You go through the mouth, use your laser precautions. It's a flexible fiber laser because you can't reach to the distal end, and you basically just laser the whole lesion. What the laser does, it produces a very crusty lesion, and you can just use a cupped forceps and remove the rest of the lesion. Distal tracheal granulomas are pretty hard. If you don't have a laser, one of the things which urologists have is known as a Bugbee cautery. Urology carries it. It's like their basic instrument. It's like an ENT cautery. It's a flexible cautery. And if you ever are in a situation where you have one of these, where you have trached a child and there is a big granuloma at the end of the trach, you can actually use the Bugbee cautery. It's a flexible cautery. You can tape it to the side of a flexible scope and basically pass it through the trach, and you can cauterize that granuloma. Or if there is a distal bleed. So that Bugbee cautery is a pretty nice tool if you don't have a flexible laser. So this is a massive distal tracheal granuloma, and we are going to just laser or zap through it. And then I'll use cold steel instruments to basically remove all that scar tissue. Subglottic cysts. Bilateral subglottic cysts are hard. Never do both the sides in one setting. You'll form subglottic stenosis. Always stage it. Do one side first and then go to the other side. So again, I use laser. You can use microdebrider in this. You can use cold steel instrument. Laser works good in my hand, so I like using laser. You hold the lesion, you pull it laterally, and then you laser through and we stage it. We do one side. We bring the kid back after 5 days to the other side. Always stage bilateral subglottic. So it's a clinical diagnosis. History of intubation, or most of these cysts arrive from preoperative. So most of these cysts are secondary to intubation. Most of these cysts are secondary to intubation. So, and Good. This is a case of a lingual thyroglossal duct cyst. Again, if you look for it, you're going to find it. You can see a bulge right over here on the epiglottis. So the kid came with stridor and failure to thrive. And when you scope, you'll see this massive cyst. So it's a lingual thyroglossal duct cyst. It's not your routine thyroglossal duct cyst. So a couple of points you have to remember about lingual thyroglossal duct cyst. If you diagnose this, you have to get an ultrasound of the neck to see if the child has thyroid or not, because this might be the only thyroid tissue which the child has, and you end up removing it, and the child, you send him home, and after 3 years, he's a cretin and he doesn't have any thyroid function left. So make sure if you ever diagnose a lingual thyroglossal duct cyst, regardless, even if you diagnose a cervical thyroglossal duct cyst, you get an ultrasound neck and a thyroid function done post-operatively and make sure the child has functioning thyroid. So lingual thyroglossal duct cyst, same, you suspend with a Lindholm laryngoscope, and then again, it's a laser, so we end up lasering the whole, you grasp it with a grasper, and then you laser all around it, and you remove the lesion. It's a one setting, it doesn't come back, it's gone, it's gone. So vallicular cyst, again, we saw this video before, and surgical excision is pretty simple and takes care of it. Subglottic stenosis, so this is a small web in a 3-month-old child post-intubation. Very simple, use a sickle knife. We call it a trifecta incision or a Mercedes-Benz sign. You make a cut over here, you make a cut over here, make a cut over here, put a balloon in. So if you don't have balloons, what are your options? They are dilators, like you have, I'm forgetting the name of the dilators which we used to use, but there are dilators available with pediatric surgery, which they use to dilate the esophagus. So you can use those dilators. I haven't never used them because we have balloons over there. Using an age-appropriate endotracheal tube and inflating the cuff is another way, but that cuff is a compliant cuff. So it basically doesn't give you that pressure which you are looking. The balloons we use are non-compliant, meaning they don't comply to the tracheal lumen. So that's a difference. So a poor man's balloon would be like an age-appropriate endotracheal tube. You put in and you inflate the cuff right over there. Inject steroid before inflating because that gives the steroid goes everywhere. So you put the cuff in, you inject steroid, put the cuff in, inflate, bring the child back in a week's time. Something as like this will take care in one setting. You don't even have to do it again. Excellent question. So you see this, it's a thin scar. So as we learned about grades of subglottic or tracheal stenosis. So grade 1, where you have less than 50% obstruction and the scar is not thick. And thick means less than 7 millimeters. Those do pretty well with incision and dilation. If it is a thick scar, which is more than 7, 8 millimeters or 1 centimeter thick scar, then you can try doing laser and dilating. It won't work. You'll have to do a tracheal resection in those patients or an open airway procedure.
So does this stand for adults also, this 8 mm?
Yes. It's actually data from adults because in children, we usually end up, it's hard to find these small, thin, flimsy webs. Usually it's thick stenosis which develops, so they end up getting open resection. So the data of 7 millimeters or to 8 millimeters is actually an adult data.
That is very nice of you to elaborate it because we know the treatment option, but we don't know in which condition this should be applied or in which condition the other option should be applied. So it is very informative.
Yeah, and I don't know if you use mitomycin C or not.
Mitomycin C is available and sometimes for corneal atresia and all we do. But these cases we basically get post-traumatic stenosis more. And in that, this subglottic collapse of the mucosa is there. And then again, we are fixed what to do about these cases.
Yeah, so laser is, that's why you need to have laser. Laser is a great tool in these situations. Gives you precise cut. It doesn't cause collateral damage. Because you can have a lot of collateral damage with other things and you can actually produce worse results with coablation or something. So laser is a great tool. No. You have to intervene every time a patient has symptoms. So it's not dependent on the percentage. Like if the patient has symptoms, then you have to intervene. But if the patient is fine, then you don't have to do it. But that's exercise. Yeah, exercise, and that's an indication for doing something. But if the patient is doing, that's the number one principle in surgery: do no harm. So that means if the patient is fine, you don't want to you should not be operating on the patient. But if the patient is having exercise intolerance, airway obstruction, or you're thinking of doing a tracheostomy in the child, especially post-COVID, I'm pretty sure you've got a lot of males or patients who were intubated for COVID, and post-COVID, they have all sorts of posterior glottic stenosis and you don't know what to do. That's where laser dilation comes. They work pretty well. Laser dilation, steroid injection, mitomycin. It's pretty standard.
That is good.
So these were the Jackson dilators. I just put it over there. The issue with them is they actually give sharing force. So if you're putting in, it not only acts on the area you want to address, it also traumatizes the area around it. With the balloons, you can actually hit the area where you're looking for. The issue with balloons, they're expensive and they're not available easily. In India, we don't have a cheaper balloon option available at the moment. So you just have to do with the Jackson dilators or an endotracheal tube essentially. Same principle. So this is a very nice case for endoscopic laser. You see, it's a thin scar. When you look at one of these, we can laser and we can balloon dilate it. So it's pretty easy to do these cases. You laser the scar and then you essentially put a balloon and dilate it. And post-operatively, it looks pretty nice. Like you don't even see if the patient had tracheal stenosis. So this is the balloon. I use an airway eclairant balloon when you dilate it. It's pretty simple. So, okay. Any questions about endoscopic techniques? Because the last video will be about open airway surgery. Okay, good. So this is a case of a single stage laryngotracheal reconstruction. So the way you reconstruct the airway is there are two types of surgeries you can do. One is we discussed expansion procedures and resective procedures. Expansion means you make the airway bigger. Resection means you just remove that stenotic segment. Expansion is easier because it's technically less challenging. Resection is technically more challenging in children. So this is a case of a patient who had this is a typical standard case which will come to your clinic. The child was a premature infant, failure to extubate, got tracheostomy, now comes back at 2 years of age, parents want the trach out, and you're like, okay, is he tolerating a Passimir or a capping trial? No. You take him for a bronchoscopy, you see suprastomal collapse, or you see subglottic stenosis. So your next step would be, we want to do an anterior costal cartilage graft. So that's the surgery. Single stage and double stage, as we discussed. We are going to remove his trach in the same setting as the surgery. So it is a single stage. If I would have kept the trach and just done the surgery above the trach and removed the trach later on, that's a double stage surgery. So remember the difference between single stage and double stage. So what we first do is we have removed the tracheostomy. We have put an endotracheal tube through the trach. It's like we put an endotracheal tube and then we suture the endotracheal tube through the trach. The first step, I usually harvest my rib cartilage first. Some people do the neck part first and then come to the rib. I use the rib part first. So the first thing is to harvest the costal cartilage, and it's pretty standard, but we'll just go over and see if you have any questions.
I will tell you one thing. I think for full audience, like I have attended many workshops for regarding larynx, laryngeal reconstruction. There is a beautiful center run by Dr. Raman in Manipal Center. And a lot of insight came to me from that also. And I used to, since 5 years, I'm following you and all. But this audience, I think this is the first introduction to them for all these laryngeal things, laryngeal cleft, stenosis, like they might have read it for exams, but practically getting exposed other than doing a tracheostomy, no one knows. So I think this will be an eye opener to them, and then they will start diagnosing the cases and then further ahead. So basically that's why they are not having that much of interaction. You might be thinking why they are not interacting. So basically they are all in the learning phase of it.
No, absolutely. This is not common things. These are rare.
These are all very rare, and
Yeah.
for adults also this criciotracheal resection we have to arrange with our cardiothoracic. I have to request them, because you have to do a lot of tracheal pull-up or in-nominate. See, we can do it, but we have to have them in backup.
But that is what makes you better, or not better, but more
Not better.
advanced.
I just want me to become a good teacher,
Yeah.
which is giving them guidance that you can, if you want, you can enter this field.
Exactly. So that's a great way of teaching the residents, doing the complex cases. That's why.
And getting good teachers like you with me.
that's
We have a very
great
good
approach.
team of teachers then.
Okay.
Sir, as a tertiary care center, we get a lot of laryngeal trauma cases, accidental, suicidal. So we would really appreciate if you would give us input to how to repair and certain points to keep in mind, what to do and what still better what not to do. So that is one area we can get a lot of help from you.
No, absolutely.
And it was between them every first morning
Closest.
Can we avoid tracheostomy in children in such cases?
I would trach that child. Like definitely a trach repair, and if possible, you might need to put a stent in as well for some time. Yeah. Yeah, initially trauma cases, trach should be pretty, you don't want to take a risk, because even if you repair it, the child will have so much of edema and swelling, and after the surgery, you won't be able to extubate the child. So it makes no sense avoiding a trach in this scenario. You will trach the child, do a repair, and then make a decision whether you want to stent it, like put a stent in, keep him intubated for some time, and then do the trach as a second stage, but do the trach and then put a stent in. So those were some of the decisions. Placement of the stent depends upon the amount of mucosal trauma. If the mucosa is pretty traumatized and flopping into the airway, then the stent will keep it so it heals in a nicer way.
How long the stent should be kept?
At least for 2 weeks, 2 to 3 weeks. That's a great question. So we have celastic stents. So celastic stents, I don't know what is available in India. So a Bulkar is one of the stents we use. Rutter is the other stent we use, but celastic stents are great. So any celastic stent would work. If you don't have stent, then you can use a cut endotracheal tube.
So age appropriate, yes, sir, we do that. So, but a lot of time we see a lot of granulations because of that stent.
Yeah, so Ciprodex is the answer to that question. If you use Ciprodex regularly, the question is, how do you give Ciprodex if the patient has a trach? Like, how are you going to reach that area So there are a couple of ways to do it. Some people put drops in the trach, put a thumb on the trach and have the patient cough. So that it basically acts like an internal nebulization and it goes everywhere around the stent. The second way is if the patient tolerates, then you can do intermittent capping and just nebulize from above, which is hard to do, but most of the patients won't tolerate. So you basically put drops in the trach and the Ciprodex drops, they're pretty cheap over here. So you just put 3 or 4 drops, have him cough up. That's why stenting is not that great, especially with the endotracheal tube, because it's not meant to, and make sure you have no sharp edges in the endotracheal tube when you cut it. So this kid would have been managed with a trach, suturing of the primary and putting a stent in depending upon the mucosal. That would be my approach. I don't know what ended up happening. What did you
We
do?
will do pretty much the same.
Okay.
Like I keep on asking myself what to do with the child with subglottic stenosis. How long are we going to wait? Is the cricoid which is stenosed grow proportionate to age, or it will keep on increasing? The resistance will keep on increasing because it is not growing in proportion. So there are many queries which I think there are we still need to answer about it. So if there is a subglottic stenosis, 6 months old child is coming, not in respiratory distress, but just for diagnosis. We diagnose it on the basis of CT, and the tube is not going, so anesthetists are refusing to take it, the child. Now, should we do tracheostomy when we have made a diagnosis, or should we do a tracheostomy when the child is in distress or he is developing some problem symptoms?
Those are hard decisions. Airway is all about decision making. It's not a technical thing, it's decision making, and it takes a while to develop those decision making skills. But it all depends upon your setup. Like if your anesthesia is happy, is comfortable taking the child back to the OR, of course, you don't want to trach the child. You want to do a bronchoscopy, dilate the patient, see if that helps. If that doesn't help, you don't want to leave the child because he's going to get sick and has already compromised airway, is going to get more compromised. And if he lives 40 minutes away from a hospital, he's not going to make it when he gets sick. So the easiest way is safer, better. So you have to put a trach in and make it safe. You want to save a life. That's the end point of whatever we do.
Like one case we had, she had a cardiac surgery done with a very less output of 15 to 20 or 25% of the cardiac output. And she also had subglottic stenosis. Now there was a tussle between two of us. What to do, let the child gain the weight and all. So again, every child is very different and we have to take a decision according to that. But we should do tracheostomy and then we should do this expansion surgery as per you.
Absolutely.
And endoscopic anterior and posterior split will help up to which age of the child?
If it's in neonate, like within 1 to 2 months, I won't do it
After that.
Yeah.
So after that,
So
you'll require a thyroid ala
thyroid
to,
gland graft.
okay, and you will take an oval, or what type of shape you prefer?
It's a spindle shape.
Spindle shape, right?
It's basically a boat.
Okay,
because
and what, only 1 mm expansion you expect, or you do expect the, what is the assessment? How much expansion you prefer, and what is the decision to make an anterior split and anterior and posterior split? There has to
So-
be some criteria.
Absolutely. So grade 2, you can manage just by an anterior graft. So once we finish off the surgery, I'll show you how thick the.
Okay, I'm going out of your topic. Sorry,
No,
sorry
no,
to bother you.
We'll cover all this over here. But
So we'll discuss after this then.
yeah,
That will be better.
okay, perfect.
Fine.
So we're going to start with how to harvest the costal cartilage. So you make your incision. You can be pretty fast in this area. There's nothing of importance. I use a Bowie. We go through the muscle and we directly land up on the cartilage. So a couple of things. The Wheatlanders are really helpful. These are your ear instruments which you use for mastoid. It gets rid of one of your hands. The rib we are harvesting is actually 4th or 5th. So just in the inframammary crease, you're going to make your incision. If you go down, you end up with synchondrosis in the joint and it's very hard to remove it. 3rd or 4th rib is pretty nice. It makes your job pretty easy. So you go with the Bowie all the way to the cartilage. When you have exposed the cartilage, make sure you go to a bipolar. You don't want to cauterize the perichondrium over the cartilage because that is going to go inside the airway. So I usually go through the muscle with a regular cautery, but as soon as I reach and expose the rib, I go to a bipolar so get more precise cauterization. So once you have exposed the rib, what you try to do is you look for the costochondral junction. So you want to harvest the cartilage, you don't want to harvest the bone. So there's a costochondral junction, and at that junction, there is what we call as a blue line. So you'll be able to differentiate where the cartilage is ending and where the rib, the bone is starting. And that is known as a blue line. The other way to diagnose it is you take a needle and basically puncture on the cartilage. It will go through the cartilage, but you'll have stiff resistance on the bone. So you'll be able to find the costochondral junction. So you really, that is your end limit for harvesting the costal cartilage. So you see our exposure is pretty nice. I put in 2 Wheatlanders. Now what I'm doing is I'm actually going to control or cauterize the superior and the inferior aspect of the rib. So what we want to do is essentially what you do in a septoplasty. I want to keep the perichondrium on the medial side of the rib intact because we don't want to injure the pleura. So what comes after pleura is the perichondrium on one side, the rib and the perichondrium on the other side. You need perichondrium on one side to go inside the airway. So what you're going to do is essentially cauterize the superior edge of the rib, the inferior edge of the rib, so it doesn't bleed. Make an incision on the superior edge, make an incision on the inferior edge, and use your same Freer or Cottle's elevator used for septoplasty. Same procedure. You basically elevate the perichondrial flap on one side, try to keep it towards the pleura. Always forces towards the cartilage. You don't want to produce a pneumothorax, don't want to make a pneumothorax. So it's a pretty simple surgery, but there are just some nuances to it. So what I'm doing is I'm bipolaring the superior edge. Now I'm making my incision on the inferior margin, and then we are going to use the Cottle's or the Freer elevator, and I'm lifting up the perichondrium on one side. And I'm going to do the same on the superior side, and then I'm going to connect the superior and the inferior incisions. I use a Sen retractor or an L-shaped retractor, and we basically cut it. So we are going to cut on the inferior, the lateral margin first, and then the medial margin. If you see, I'm cutting on my retractor, so we don't cut into the pleura. And that's the rib. And then you check for leak. You put a lot of saline in it, and then you have the anesthesia do a Valsalva so you can check for any air leak. If that is not there, then you close the incision. I put a Penrose drain in, like a regular rubber drain. So if there's any issues with this. Okay, and then we go back to any questions about the cartilage. So 4th or 5th rib is the best. Don't go down. You'll end up with the synchondrosis. It's not great in that area. Make sure you preserve perichondrium on one side. That side goes inside the airway. Leave perichondrium on the other side. Do a airway leak test at the end of the surgery so you don't see any bubbling, meaning there's no pneumothorax you've produced. So I have the luxury of 2 teams. So while I'm doing this or my fellow is doing that, the other team is actually opening up the neck. So we end up doing these procedures within 2 to 2.5 hours. Otherwise, it can take a long time harvesting the rib and doing both of the things. Now we focus on the neck part. So this is a single stage. That means we are going to remove the stoma at the same time we do the airway recon. So you look at my incision. My incision is ellipse around the stoma. If it was a double stage, I would just make a single incision like a thyroid above the stoma, if it was a double stage. But since it's a single stage, I'm going to remove the stoma along with the skin and everything. So we're making an incision, and then I use bipolar, and the stoma is all removed. So that's the first step. I use these skin hooks. These are known as Lone Stars. These are pretty helpful. They help to retract the tissues. So you don't need much help doing this surgery. So you see how I've removed, and that stomal cuff is around the ET tube. Rest we have exposed the neck. You get the strap muscles out again like a thyroid. And now we are doing the midline dissection, and I'm exposing the trachea. and we keep on going laterally. You don't want to go majorly lateral because your recurrence are going to be there. I use a lot of bipolar in my dissection and it's pretty scarred up. So complete midline exposure. And then we start working on the cuff of the tissue. So you see how the cuff is getting removed. Complete removal of the cuff, the tube is still in. And the next step is to put stay sutures again. So you don't want to lose the airway. Any airway reconstruction you do, put stay sutures. Again, paramedian, you put proline sutures. So if you lose the airway while you're doing anything, you can always have control of the airway. You do a trach resection, slide, trichotracheal. This is your safeguard. Okay, so now I'm going to do my cricoid split. So I use a beaver blade, but you can use a number 11 or number 15 blade, and you do a cricoid split. So how do you do a cricoid split? You start from the cricoid, you split the cricoid, you come down to the area where you want to open it up. So what people do is we have somebody giving us a bronchoscopic view from above to exactly know where your cricoid split goes. You split the cricoid, you have somebody go through the mouth and give a bronchoscopic picture so you know where you are going. So you do the cricoid split, you basically cut the first or the second tracheal ring and you go up a little bit to take 1/3 of thyroid cartilage. So that's a full cut you basically produce. If you go more than 1/3 of the thyroid width, then you'll end up doing a laryngo fissure, meaning you'll cut the anterior commissure, and that is very hard to repair, and the child lands up with hoarseness and dysphagia. So this is an important step. So bronchoscopic guidance of the cricoid, first and second tracheal rings, lower part of the thyroid cartilage, like just remain 1/3. So in children, you don't have a major big brachothyroid membrane because everything is clamped together. In adults, you have, yeah, it just goes in one. And then you have somebody guiding from above, like with the bronchoscope. You don't want to go superiorly. No, it goes through and through. Through and through the mucosa. Yeah, through and through the cartilage, through the mucosa. You will be staring at the posterior wall, essentially. So. Okay, so what I'm now doing is I'm actually freshening the margins of the, so at this time, this is a very critical portion. This is a single stage. So we have to swap the tube now. I have to remove this tube and I have to put a tube through the nose. So that's where your anesthesia comes into being. I do it myself. I'll scrub out, I'll put a DL and intubate from above. And my fellow or my resident is going to pull the tube out through the neck. So this is very important, and I'll repeat the video is how we swap the tube. So I've removed the endotracheal tube. I'm going to push the endotracheal tube from above. I tie a silk thread through the end of the endotracheal tube, so it makes it easier for you to pull. And then you measure the graft width. This is also very important. So how much length of the graft you need? There are 3 dimensions you need: the length of the graft, the thickness of the graft, and the distraction. So distraction is the amount, the width of the graft you're going to place. That's much amount of airway you're going to increase for the child. So we use a caliper. So this is the first measurement, which is the length of the graft. And then we don't have a video of how we shape the graft. So that's another very important step. So the graft is shaped like a boat. So it's a boat-shaped graft. And that's something which you have to practice. So if you practice, you can practice it on anything. Like we have a celastic block. You can practice how to carve out the graft. It's pretty simple. You can use a pig cartilage to carve out the graft. To practice carving out the graft because it's important the graft should be in a good. So if you look at the shape of the graft, I don't have a separate picture. So this is we leave a flange on either side of the graft. So you have a cartilage block. You basically get a spindle shape in the middle and you leave flanges on either side. So the middle part is the distraction, what you want to give. The flanges width of the flanges should match the width of the trachea, which you measured. So if it's 2 millimeters, that's the width of the flanges. And it's all a boat shape, like a spindle shaped graft, which you're going to place down. One of the things which will really help you is, I don't know if you have seen this retractor. The major issue with airway surgery, if you do a cricotracheal resection or a tracheal resection, the sutures all mess up at the end. Like you don't know which is going where. So we use this, this is a hemorrhoid retractor actually, to basically place our sutures, and it's really helpful. So now that you have this graft shaped, one of the assistants stands at the head end, holds the graft in a debaki, and then you're going to stitch the graft. And the way we suture the graft is we do mattress sutures. So you're going to go through the cartilage, submucosally through the trachea, come out through the graft, go back through the graft, and go out through the trachea. And you do 3 on one side, 3 on the other, and then we are going to parachute the graft down. So what we are doing right now is we are going to place these sutures. So you'll see, I'm going through the trachea once. We come back through the graft right at the edge of the flange and the spindle-shaped distraction we have made. We go back through the graft and back through the trachea. So this is how it looks like at the end. Okay. So this is how it looks like. We have 3 on one side, 3 on the other side. And we tie multiple knots, at least 6 or 7 knots. We don't want the knots to split up. And at the end of the case, we are going to cover it all with a tissue or a tissue glue, as we call it. We check for air leak, and then we put tissue on top of it. And then we close the neck. And the patient is intubated for 6 days, 5 to 6 days after the surgery. And then we bring them back on day 5. We extubate them in the operating room and look at the graft and whether it has healed up or not. And then you close the neck. So this is the post-operatively. You see the graft is all mucosalized very nicely, big and white, patent airway. The post-operative, so single stage you should start doing when you have a very robust ICU and when you have done this for a while, because single stage is risky. You don't have any airway backup. If the graft fails, if the graft gets infected, if the endotracheal tube comes out when the child is intubated in the PICU, you have nowhere to go. Like, it would be a disaster. So single stage is something we reserve for if you have done, if your PICU is pretty, knows what they're doing. Because once the child is intubated for 6 days, you don't paralyze the child. You keep them heavily sedated. The first 3 days they are paralyzed, then we wean off the paralytic. Because I don't want them to go into a significant withdrawal once we remove the tube. Because if they withdraw, they're going to have respiratory depression and we'll have to intubate them and all the surgery goes haywire. So if you're starting this, do a double stage. Keep the trach in. You can do anything above the trach. The child is going to be safe. You can do anything. He has a safe airway. Trach is the safest airway in the world. So nothing can go wrong as long as you have the trach in. So you can do anything above the trach. That's what I teach my resident fellows. If you're starting it out, do a double stage. Do the same thing. Keep the trach in. Put the graft over the trach. Once you are comfortable, you've done quite a number of them, your PICU is nose, then start doing single stages, especially in kids who have a trach. So you remove the trach in the same setting. In our setup, we do single stages in patients where people don't even think, like cardiac transplant babies. We'll do single stage. We'll do single stage in transplant babies where there's inherent risk of immunosuppression and all that stuff. Because our system supports that. In your system, it might not happen. So a double stage is the way to go. Same surgery, but doing it as a double stage. The other is the resective cricotracheal resection, which is an entirely different talk. I just wanted to keep it simple, like it's just one surgery, at least a supraglottoplasty, tracheostomy, and an anterior graft. Those were my 3 aims. Any questions from online? Anybody had questions? And Yeah? Do you want to learn anything else? Yeah, absolutely. So coming to your DL scope, that's the basic skill you have to develop first. Again, it's 50% is anesthesia game in all of the evaluations. You need to have trained anesthesiologists who are comfortable in scoping in keeping the child spontaneously breathing. Once they are accustomed to that, you have to get that fear out of your head is something bad is going to happen. Because if you think something bad is going to happen, it is going to happen. Like there's no question about it. You have full control over the airway. You just have to put a tube in a tube essentially, and you can do it. As long as you can DL the child, he doesn't have craniofacial issues, you have a DL, you can expose the airway, you can put a tube in. And once the tube is in, what wrong can go? Nothing. No, it's a clinical diagnosis. You size the airway to get an assessment of how bad the stenosis is. So that's the whole point. You don't need to put a tube into, you can sometimes
just
see,
size
you
it.
can just see it. The reason we size it is because it's a standardized way of knowing how bad the airway is and how is it going to look after the procedure. Sizing, for me, decision making is based on what I see rather than the grade. Like if I see a thin, flimsy scar, I know it's amiable to endoscopic incision and dilation. If I see a thick scar, I know it's not going to be, he needs open airway surgery. If it's a grade 2 stenosis, and again, I can explain to you it's grade 2, but when I see and I feel it just needs an anterior graft, it's an anterior graft. When it's completely shut down, it needs both an anterior and a posterior graft. So it's pretty simple. You don't have to put a tube in. Just gives you a common language where we can talk about it.
So like we are going right up to the vocal cord and we are seeing the vocal cord and we are doing this fast evaluation of a newborn or infant.
Yeah.
Anything more we should do in this case,
Yeah. So
except for examination?
so once the first step is you talk to your anesthesiologist, they're going to put IV lines and everything. They'll give some propofol. You go in, you take your DL, any DL, Macintosh, whatever, Wisconsin, straight blade. In children, one of the things about doing a DL is you do what we call as a vallicular DL. You don't take the epiglottis in your laryngoscope. You go in the vallicula, and that is very important because there is a lingual epiglottic ligament which hinges the epiglottis to the tongue. If you press on that ligament with your laryngoscope, the epiglottis is going to open up. So the movement of the laryngoscope is towards the feet. First, you push it in, and then you flick it up. This is the game changer where you can intubate almost anybody. That flick will make your airway open up because you're essentially pushing on the epiglottic ligament, and that will open up the epiglottis and you can intubate. Epiglottis is a very important landmark which guides you where to put a tube in a small baby because the airway is very crowded. You won't be able to see where you're putting the tube. So don't take the epiglottis with your laryngoscope. Try to do a vallicular insertion and then open up the epiglottis and then then topicalize the airway with a 4% lidocaine or 1% lidocaine, depending on the age of the baby. If it's a small neonate, you'll do 1% lidocaine. And then you put your Hopkins rod telescope in, making sure you stay in the midline. If you start touching the back or the front wall of the trachea, the child is going to start reacting to that, and then you'll have to intubate the child and all that stuff. So we do like 1,000 bronchs a year, so and it's pretty doable, provided you have supportive anesthesia. Like, and that's simple about DL. You do a diagnostic bronch, you try to look out for lesions. Do a flexible scope first, make sure there's nothing wrong from the nose to the larynx, and then do a full DL. That's a full airway evaluation. If you still don't find anything, then do a drug-induced sleep endoscopy. And for a DICE, it's basically the same cocktail, propofol, same drug, SIBO, but it just has to be managed in a way where you hear a snoring sound. That's the right plane. It's not deep, super deep. It's a little bit above awake and being super deep for you to do a bronch. So it's again with anesthesia trick, you can get them into a plane where you can do a DICE and you'll see different lesions come up. The second question was about decannulation, the pediatric decannulation. So it's a step-by-step process. So you decide, oh, I want to decannulate the child. The first step is to put a voice valve or a Passy-Muir valve on it. I don't know if you have it over here, but the first step is we put a voice valve, which is a one-way valve. So the child can vocalize or talk. If he doesn't tolerate that, that means there is something wrong in the supraglottic airway. Like he's not able to generate sufficient pressure, that means there's some narrowing. And then you take him for a bronchoscopy. All kids who are planning a decannulation need a bronchoscopy, period. Like there's no question about it. You cannot decannulate a child without doing a bronchoscopy. Most common thing which will prevent decannulation is a suprastomal granuloma, which is easily manageable. You can just remove it. Second most common is a suprastomal collapse, where you can do an anterior graft easily, do a double stage, keep the trach in, do the graft above, easily you'll expand the airway, have a wide airway, you can remove the tracheostomy tube. So if he's tolerating the Passy-Muir valve, the next step is capping trial. So you'll cap the trach. You'll send the baby home with a cap, tell the parents, cap it for 30 minutes, make sure the child doesn't turn blue, is not having respiratory distress. If he has, remove the cap, and then extend that 30-minute period to 1 hour, 2 hours, 3 hours, and then the whole day. So in US, we do a capped sleep study once he's tolerating for the whole day. And then after that, we decannulate the child. We take them to the OR, we again bronch them, decannulate the child, put a 4x4 gauze over here, send them to the ICU for a couple of days, and that's it.
Right, that's good. Here we are doing the capping for the patients because we cannot trust the parents.
Yeah, absolutely. Yeah. That's a wonderful point. And we have parents who actually want us to remove the tube, and that's what we explain. This brings about a different topic, which is drooling. And many of these kids have a lot of drooling issues where they just produce a lot of saliva because they're not swallowing the saliva properly. What we do there is we just remove their submandibular gland. We do bilateral submandibular gland excision. Very simple surgery, and it takes care of those excessive drooling secretions. If they are tracheal secretions, then we work with our pulmonologists. Sometimes they need chest physio, and some pulmonologists can work with them, pulmozyme, chest physio, they're producing secretion. So that's where that multidisciplinary approach comes. They have very good techniques of managing secretions in the airway. So talk to your pulmonologist, they'll advise you about some stuff. But that's the point. Like we sometimes, the only thing is the child has so much of secretions, that's pulmonary toileting. You cannot do without it.
So improve the chest first.
LTR, you have to give a full evaluation. You have to get a GI scope, make sure the child doesn't have reflux. You have to manage the reflux. You have to get a pulmonary lavage of the lungs done. Make sure the child is not growing any organism like MRSA. If he is, then you start prophylactic antibiotics. And then secretion management is very important.
So we have got a very wider, broader view into this laryngology along with finer details. Thank you so much, Dr. Sohit.
It's been a pleasure. Thank you so much. Thanks for
It was wonderful day. We hope to have you sometime again with we also growing together with you.
Oh, absolutely. If there are any questions, you can ask. Yeah. Yeah.
My question is regarding pediatric stenosis, sir. And that's a first, we inject your mitomycin, then after we should then in certain cases, we do that.
That's a good question. So we don't inject mitomycin, we do surface topicalization. So the first step is you want, so it's a scar. It's like a circumferential scar. And I've seen videos where people just laser the whole scar. So you're essentially producing another scar which is circumferential. You want to leave mucosa in between your incisions. If you don't leave mucosa in between your incisions, then it's all going to scar back again. That makes sense. So if the scar is circumferential, you break the scar at 3 points. It could be 4 points. It could be 3 points. 3 points is just a standard we use because we cover the 3 quadrants. Some people do 4-point incision. The trick is you don't want to excise the scar, you want to incise the scar. And the incision will be done at 4 places or 3 places. So that's the first step. Then you inject steroid. Then you inject steroid submucosally. And then you balloon dilate. The reason you balloon dilate after steroid injection is the balloon is going to help the steroid spread along the lymph and fingers. And then you surface topicalize with mitomycin. Use the pleasure and you place it on the scar for 2 minutes. And once you wash, take out the mitomycin you have to wash the wound because mitomycin is toxic. You don't want to keep it over there. You wash it with saline. So any residue or excessive mitomycin is suction back. So you don't keep it over there. So to your point, it's not essential. You can make a 4-quadrant incision. The key is to leave mucosa intact in between your incisions and not size the scar, incise the scar. So that's very difficult.
Sir, in centers who do not have lasers, so how much application is there for chemical cauterization coupled with the cold stainless steel excision? Is it comparable to?
It is not at all comparable because you are essentially bringing a flat cross, like a flat, big, massive flat mashal, the mashal. The cautery is a mashal. The key in airway surgery and laryngeal surgery is precision. You don't want to cause collateral damage. You want to basically take care of the lesion that is causing the problem. If you cause collateral damage, you'll produce more damage to the patient than helping him out. So very important, precision is the key in laryngeal facial surgery. So how can you be precise? You can be precise only if there are various instruments, and of course, laser is a whole together different talk. Like how laser works and how precise it is. A cautery is essentially a blowtorch, right? It's when
I'm talking about chemical cauterization
chemical cauterization for what?
along with cold excision,
For what? For what reason? Right.
like stenosis, polyps. I want to.
Chemical cauterization is a hemostatic. It's not an ablative thing. So it's basically you can use it for granulomas at the max. You won't be able to use it for everything else. It's not an ablative thing. So chemical silver nitrate is not ablative. It's just hemostatic. The bug bee cautery I was talking about is a flexible cautery urology has. It's pretty thin. That is something comparable, not even comparable, but that is something you can use. But for laryngotracheal surgery, you need to have laser expertise and laser.
Thank you.
But cold steel instruments work fine as well, like especially with subnautic instruments. So that's it.
So I asked a question about anterior web in a small child and what is the role of keel in a children?
That's a good question. We just published a paper in our main journal where we talked about pediatric laryngeal clefts. Placement of a keel doesn't change the course of a pediatric laryngeal web. Like what we found was the placement of a keel had the same recurrence rate and everything. So it depends upon what sort of web are you talking about. So there are 4 types of web. They've been shaded by cohorts. They are known as cohort type 1 to type 4. Type 1 is a very small anterior web. You sometimes don't even diagnose it. You don't have to do much about it. Type 2 is when half of the anterior larynx's vocal cords are fused. Type 3 is when 1/3, 2/3 is fused, and type 4 is when you have subglottic involvement as well. So type 1, type 2 can be managed endoscopically. You don't need to place it here. You can basically incise with scissors, but you have to make sure again you bring the patient back in a week's time, and you have to debride and sometimes redo the surgery. Type 3 and type 4 are the ones where we end up doing open airway reconstructions. Placing a keel at such a small age is technically very challenging. And we didn't find any difference whether we placed a keel or not in the recurrence rate. So I personally don't place a keel. I do something very different, and we published this technique way back. What we do is we incise the mucosa on one side, and then we suture lateralize the other side. So we wrap that mucosa on the other part, and the way I showed the video of suture lateralization, we put a suture in and lateralize the other side. So what it does is we are not producing two raw surfaces. One is covered by the mucosa and is separated from the other side. You bring the patient back in a week's time, you cut that stitch and then remove the web from the other side. And again, you have one mucosalized side, the other raw side. It's not going to restart together. So that's what I do. Some people just incise it, balloon dilate it, inject steroid, mitomycin, see the same thing. Heel placement, I don't think it's going to help you in severe cases. You have to do an open air with reconstruction.
So looking at your scenario of having laser also, so do you still excise it with a cold steel or you'll prefer laser in this case? Sir?
I would prefer laser.
Laser. So this is a very good concept of suturing it back and making it nice. Very new, good concept, sir. But now what is the age? Like aphonic child is there, he's crying and no voice is coming. So at what age we should do this?
Age is no criteria.
But whenever a child is fit for anesthesia, take it.
Yeah. So I've done it in like.
And how long do you put anesthesia tube or something edited tube after that?
So yeah, we intubate them for 3 to 4 days after incision.
After web excision also.
4 days of, and then steroid, bring them back to the OR. Sometimes they need another procedure done, balloon dilate, incise, steroid injection, couple of times.
You have written in your CV, sir, you do a lot of hemangiomas and all. So you might have seen many cases. So neck hemangioma, especially the tongue hemangioma, do you use propanol for that? Tongue hemangioma is really difficult. If you're exhausted, you can take a break or we can break it and we can rediscuss this issue.
So that's the whole lymphatic malformations and vascular malformations is a whole symposium in itself.
Right.
But to answer your question, the first diagnosis you have to make is whether it's a malformation or a hemangioma.
Right.
So malformations are present right at birth. Hemangiomas or infantile hemangiomas present at 2 months, as we all discussed. So malformation is something which is present right at birth. Propranolol is not meant for malformation. Propranolol is for infantile hemangiomas. So tongue hemangiomas are pretty rare. And we don't use propranolol for lymphatic malformations. Tongue is known for lymphangiomas or microcystic lymphangiomas. So most of the time it's a microcystic lymphangioma in the tongue, which makes the tongue pretty big.
Glossy.
Yeah. So and those kids can't close their mouth and it's a massive tongue. Those are the kids which end up getting a trach, and then you do a midline wedge resection of the tongue essentially to remove that big chunk of the tongue and suture the tongue up.
Okay.
So you can resect that tongue.
Right.
You can definitely resect that tongue. You have to get an MRI with contrast, make sure it's not a hemangioma. If it's a hemangioma, you start propranolol, but that would be on the age group. Like if it's a young child, 2-month-old history, 8-month-old child, then you do propranolol on that. But if it's a malformation, then the only options are two. One is sclerotherapy, which is for macrocystic lesions, if the cyst is big, and the other is surgery, which is for microcystic lesions, or even for macrocystic lesions when the cysts are very small. But sclerotherapy is pretty simple. You inject doxycycline in those big cysts. And that's
Doxycycline,
yes. And then we used to use bleomycin. Now we stopped using bleomycin. So we use doxycycline.
Very good insight. This is again a new topic to discuss. We get a lot of cases because these cases are not managed privately. So tongue cases and all these sites which are very difficult to approach, we get the patient. And even after CT angio, find it still tough to manage.
Yeah, so tongue you can resect. You can resect a big chunk of the tongue in these babies. Like you can take out the whole mid portion. Like we do a full wedge resection of the tongue.
Okay.
Sometimes we do a tip sparing surgery where we don't take the tip of the tongue because that's essential for swallow. But in these cases, it doesn't even matter. Like you take a big wedge resection, you suture the tongue, and it helps them to close the mouth. Sometimes the lesion extends into the airway, so they still need trach for that, and there is very limited things you can do. And over time, they get bigger, and then you have to remove the trach. But if it's just an isolated tongue lesion, you can do a tongue resection.
Okay.
For rest, hemangiomas, propranolol is the treatment of choice. Lymphatic malformations, you get an MRI. If it's macrocystic, you can inject with doxycycline. If it is microcystic, you'll have to resect. You have to do surgery.
So doxycycline is your choice for
There are two-
for lymphangioma.
Lymphatic malformations. Yeah, there are
Lymphatic
two agents which are commonly used. Some people use alcohol. Alcohol causes a lot of issues. Doxy and bleomycin, those were the two things which were used. Bleo causes pulmonary fibrosis, so we've stopped using it. So doxycycline is our,
And the results are good.
they're good. 60 to 70% resolve. The issue is if you have to operate on them after sclerotherapy, it becomes pretty hard.
Right.
So I personally resect all of them. Like,
Okay.
I just resect all the massive hemangiomas and like small babies, we resect them. Because it's one shot, I know it's going to work, I resect it. We map the nerve. There are various things we do to help with the surgery. Like there's a full nerve mapping team we have, which maps your marginal mandibular, vagus and everything. So you know where the nerves are even before you go into the patient. Otherwise, in small babies, you'll just cut through your
It's very
spinal.
difficult.
Yeah, you'll cut through spinal pretty easily and then you'll cause more trouble. So there are various things we do surgically to help the child. Like so that's one of the things. Nerve mapping is pretty important in these cases. But you can sclerose them as well. Equal results, nice doxycycline, nothing. You don't have to do anything. You just suck out the fluid, you inject doxycycline. You do it a couple of times and it just scleroses by itself.
It is very nice information. Nice to hear about it, sir. Many patients come to us with all these problems. And
these
thank
are
you.
rare things. These are pretty rare. And that's where if you develop this, then people will send all these patients. You'll be like, okay, we don't want to deal with it. We send it
So
to
we come up to the stage of diagnosis, resectable cystic hygroma, we excise. But many cases like this tongue hemangioma and talking about this small child, we don't know what to do. You are handling a lot of patients. Have you encountered any fibrous dysplasia or giant cell lesion of upper jaw, lower jaw? So what do you do for that? Like we have a small child with upper and lower alveolar giant cell disease.
very hardly.
So, and it will all going up to the medial wall of the orbit, and I know it will pretty spread. So whether we should curate it out or we should pull the bones, what should we do for that?
That's a very hard lesion. So we had one of them in which we ended up doing a mandibulectomy and a fibular flap.
Okay, so
But you can curate it out. The
right.
medical man, I don't know if drugs are available over here, but we work with our hematology oncologist people, and there are some medical management for this.
So we'll try medical management first before trying for this curate and all.
Unless it's causing some functional issues, right? If the vision is getting involved, then of course you're going to curate it. But if it's not causing functional issues, then talk to your hematologist or oncologist or medical people, because there are some new drugs which have come up for this.
And they're used, the lesion respond to it, sir?
It is debatable. There are new drugs, but
Because it is such an extensive upper jaw, lower jaw, how much to curate and what will be the left then?
it's a very hard disease to have. It's not a simple problem to have. So they need multiple surgeries. You keep them falling back, you curate it.
And do they, is it arrested with age, like with puberty, does this stabilize? No.
Some cases it does. One of my experiences has been with a 4-year-old where we had to curate him every 6 months to a year, and eventually this was not causing any functional issues to him, so he stopped coming.
Okay,
But some people it stabilizes after 14 years of age. And then they just live with whatever deformities they have. But many of the patients, especially in the early age, they're pretty aggressive, and the aggressiveness varies. It's not pretty, some lesions are pretty aggressive, some are not that aggressive. But it's a hard problem to have. But I would talk to my hematologist. They have some medications
First.
which they can help It's pretty aggressive.
So it was very interesting to discuss 1:1 because there were so many questions and you were able to address each and every topic which you were taking, and it was such a useful CMA for all of us. Thank you so much, Dr. Sohit, for coming, taking all the pains and sparing your holiday for us. Thank you so much.
Thank you so much for the invitation. It's been wonderful.
I invite all of you for lunch, and there you can talk, they have some questions also. And all delegates are requested to join us for dinner today at Shwanilaizi, and that we can have some relaxing time. Ritha, would you like to summarize something for sir?
Good afternoon, sir. Sir, as a junior resident here, we do have multiple pediatric calls. Mainly, majorly it is from Laryngology, evaluation of Strider, and we have not studied in depth about it. And there are so many differentials that you have given today, so many things to notice. Because apart from ideal, and then ma'am had guided us regarding required CT scans or MRI, and wo chhod ke ma'am at times does bronchoscopy. But what else to look for and what else to study, we did not know. After you outlined the various DDs, now we will have a direction. We will also be able to understand we will have a direction towards the approach that we need to take regarding the pediatric cases, because pediatric cases for us are really difficult to understand at the first go. So, sir, it was really enlightening, whatever you presented today.
Thank you for the feedback. That was exactly my objective. So I'm glad my objective was met. It's just simple things. Like, let's do the simple things correctly, and then we can talk about more advanced things later on. But just start off with something. So. Thank you.